All right, now let's go back to the screen and let me know when you can see the slides.
We see it.
We can see them.
Okay, and let me make sure that recorder is on. Okay. All right. So what I was just saying is, first I talked about how airflow moves, and we were talking about pressure. Okay. And I said it moves from what direction when we're talking about pressure?
High to
High
low.
to low.
Low.
High to low. So whenever we need that air to move, the pressure it's going to has to be lower. So if you need to take a breath, the pressure in your lungs has to be lower than it is outside. Okay, for that air outside to move in, and vice versa. If you need to get rid of the air in your lungs, then the pressure in the lungs has to be higher than what it is in the atmosphere. All right, you already know that oxygen is being transported in that blood out to the tissues. That's how your cells function. You know that carbon dioxide in the blood is a waste product. You can have a certain amount of it. Too much is going to make you what?
Hypoxic.
It is going to make you hypoxic, but let's think a little bit more about it. Why is it going to make you hypoxic?
Because
What
you have
is
more CO2 in your blood than oxygen.
okay? What else is it going to make you? What do we call too much carbon dioxide in the blood?
Acidosis.
Acidosis.
There's another name for just too much carbon dioxide.
Isn't it
Hypocarbonemia.
Hypercapnia.
hypercapnia?
Hypercapnia. Okay. Now, acidosis is when you have too many hydrogen ions in the blood. Okay. But because carbon dioxide, as I call carbon diacid, because it's an acid, can contribute to that. All right. Two anatomical areas, that upper respiratory tract, you have flora living there, resident flora, which are supposed to protect you. But if you're immunosuppressed, they can harm you. The lower respiratory tract, which should be sterile. In that upper respiratory tract, you have your nose. So there you have hair, you have mucus, and that hair and mucus is getting rid of any foreign material coming in, and it's helping to heat up that air a little bit and give it a little moisture as it comes into your lungs so it doesn't shock them like a freight train. Nasopharynx, this is where one set of tonsils is, and you have another set of tonsils called palatine tonsils. So pharyngeal tonsils are going to be in the back wall of your nasopharynx, and then those palatine tonsils are the ones when you open your mouth, you can see it. It's at the back of the oral cavity, and that's lymph tissue. Lymph is your immune system. So anything that's in your immune system is going to fight. So anything coming in that mouth off a fork, or your fingers or anything you put in that mouth, that lymph tissue there is going to try to protect you by scarfing up the bacteria or whatever's coming in there. All right. So this is just a picture of the respiratory system. You should kind of have an idea of what it looks like so you know where everything is in case something's broken, because that's what you're looking at. What's broken and how does it affect the body? All right. Your alveoli, if you look down there on the left, that's those little grape like clusters where gas exchange takes place. Those need to be inflated. So there are a couple things that help them remain inflated. If they have something in them like fluid or bacteria, because you have something like pneumonia, then you don't have the proper ingredients in there, and that air exchange is not going to take place the way, or that gas exchange, I'm sorry, is not going to take place the way it's supposed to. That's going to affect that. It's also going to affect the sound of the lungs. The lungs are supposed to have air in them, which is a mixture of those gases that help you breathe and help perfuse your tissue and do other things in the body. All right. In that oropharynx, the food is coming in. You have the epiglottis there. That protects the airway. So it closes over that hole there so that you don't aspirate. It protects the body from sending food to the lungs through that right bronchial and allows it to go down into the esophagus. You have two vocal cords there, and then you have the trachea. The trachea has these C-shaped rings. Why do they put that in there? Because those help form the trachea. It helps protect it. It helps it to elongate. It helps it to bend a little bit. So it gives the trach a little bit of structure. And then your bronchioles, which there's a few of them, big ones, small ones, they're all bringing that gas in and out of your body to exchange it. That alveoli has really thin surface area there, really thin membranes, because that gas exchange has to take place. And then you have surfactant there. That surfactant reduces the tension there and helps to maintain inflation. So that's important, especially when you breathe out. Okay, you're going to have some residual gases that are going to stay there to help keep those alveoli inflated. And it also helps you to breathe in between when the body's doing this whole process. And at the alveoli, that is your end point for inspired air. They like to ask that question a lot of times. So your end point for inspired air is at the alveoli because that's where the gas exchange takes place. Ventilation itself, that's just the process of breathing in and out. Okay, and it depends on that pressure gradient. You got to know that. We call it Boyle's law. So Boyle's law means that the air is moving from high pressure to low pressure. And you already know that because you just said it. The pressure is higher in the atmosphere than it is in your alveoli. So when that happens, it allows the air to move in from the atmosphere into the lungs. Okay, so what happens is that nerve, what nerve is it that's going to stimulate your diaphragm? What nerve? What nerve stimulates the diaphragm and the
Phrenic nerve.
Okay, phrenic nerve is going to stimulate. Okay, the diaphragm is going to drop down. Your intercostal muscles will be stimulated, so they're going to push out. The lungs are going to physically expand here. And because the area is getting bigger, the pressure is getting
lower.
This is the only way inspiration can happen because air has to move from high pressure to low pressure. Okay? So as the air gets lower in those lungs, the air is now able to move out of the atmosphere into the lungs. And the opposite happens when you expire. Diaphragm comes back up, ribs come back in. Now we have a small area. Our thoracic cavity is smaller. And because it's smaller, the pressure is higher. Pressure is higher here now than it is in the atmosphere. So the pressure can leave from the lungs and go out into the atmosphere. Does inspiration require energy?
No.
Inspiration. Does inspiration require energy?
Yes.
Yes.
How about expiration?
No.
Yes.
No. Expiration is a passive process. So inspiration needs energy. Expiration does not. All right. This is just telling you everything I just said. But you got it. Okay. Your what nerve?
Phrenic
nerve.
Stimulated diaphragm drops out. Everything moves out. Okay. Pressure will decrease. Atmosphere pressure is greater now than in the lungs. Air moves in. It's time to breathe out. Everything comes back up. Diaphragm comes back up. Ribs come back in. Pressure is now greater or less?
When
when your thoracic cavity gets smaller, when you're after you've taken a breath, your thoracic cavity is now smaller. How's the pressure? Higher
It's
or lower?
greater. It's higher.
Higher than the atmosphere. So now it can go out for expiration. Okay, you got to know these three. They could test you on a couple other ones. These are the ones I see. All right, tidal volume, that's just the amount of air you're breathing out during normal inspiration and expiration. Remember, I said you have a little bit of air that stays in the lungs and keeps those alveoli open and keeps that oxygen exchange going on. That's your residual volume. And then vital capacity is the maximum amount of air that can be moved in and out of the lungs with a single inspiration and expiration. Again, this is just giving you a description, okay? This is right in your respiratory packet. And it's in your book. This came right from your book. All right, skip it. All right, so you also have receptors in the body, and those receptors are going to respond. Remember, your cerebral cortex, your pons, your medulla, those are controlling the rate and the depth of the breathing, okay? You have chemoreceptors, and those are going to sense carbon dioxide levels, oxygen levels, central chemoreceptors, okay? They're going to sense carbon dioxide levels. That H plus, that's hydrogen ions. And then you have stretch receptors in the lungs. So here's your normal cycle right here, okay? So the body senses an increase in the carbon diacid or dioxide, okay, in your blood and your cerebral spinal fluid, and that's going to stimulate the chemoreceptors in your medulla. The medulla will stimulate the inspiratory muscle. Oh, what were we talking about? What is the medulla going to trigger then?
The phrenic nerve.
That phrenic nerve, and your inspiratory muscles are going to be stimulated. That's going to increase your respiratory rate. And what's going to happen?
You're gonna retain more CO2.
So that carbon dioxide is coming out of the body, and that's going to decrease your carbon dioxide levels now. That will decrease the stimulation to those chemoreceptors, slow down your respirations, and your body will start to retain more carbon dioxide again. As long as it's working right, okay, it'll continue that cycle. For some people, it doesn't work right. Why doesn't it work right in COPD? Because when a person with COPD tries to breathe out, okay, the end of that cycle, it collapses. Those bronchioles collapse and they retain carbon dioxide. For emphysema, the alveoli are destroyed. The cigarette smoke breaks down the alveoli and destroys the walls of those alveoli. If they ask you about those two, those are things that happen. Now, with COPD, they won't ask you about the bronchioles. That's just something I know as a nurse. That's what happens, okay? So why did we use BiPAP and CPAP is because at the end of that cycle, when it collapses, the BiPAP and the CPAP force the airway open. You've heard them talk about that, right? How it forces the airway open to maintain the levels in there. Again, hypercapnia, what is it? Too much carbon dioxide or diacid, because carbon dioxide is an acid. It can lead to respiratory acidosis. Any kind of acidosis causes what?
Can you repeat the question, please?
Any kind of acidosis causes what?
Hyperventilation.
CNS depressing.
Central nervous system depression. That is correct, nurse. That is the answer. Whenever you have too much carbon dioxide, it's going to lower your pH. Those receptors should recognize that and stimulate that what? Cerebral cortex, and then what nerve?
Phrenic.
Phrenic nerve, okay? and that's going to stimulate those respiratory muscles to work. Your body is going to increase automatically without you even thinking about it, the rate and the depth of those respirations. Now, in diabetic ketoacidosis, okay, they have a type of metabolic acidosis. So they'll develop something called Kussmaul's respirations, and you have to know what they are. And they're abnormally deep respirations because the body's going acid, 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 acid. It's trying to get rid of that acid, it's blowing it off. So we'll have a little bit of hyperventilation potentially there. Hypoxemia, what's the difference between hypoxia and hypoxemia? What's the difference?
One is in the tissue and one is with the blood.
Okay, which one's blood?
Emia.
Emia. Anything emia is blood. Septicemia, bacteremia, viremia, it's blood. If it ends in emia, it's blood. Okay? So we have decreased oxygen in the blood. The receptors, again, are going to respond. This happens in people with COPD. Okay? Their body is super sensitive to increased levels of carbon dioxide. So they don't respond the way other people do. So their body responds to oxygen levels. This is why you can't give them too much oxygen, because too much oxygen will cause their hypoxic drive to shut off. Okay? The pons region of your brain becomes sensitized to the constant increase of the CO2. Remember the pons, the medulla, that's all controlling your breathing, right? So now the body has to rely on the O2 levels. Now, in most people, O2 level has to drop significantly for your body to respond to it. These clients, they have increased oxygen level, okay? So, I mean, they have an increased sensitivity to any increase in oxygen. That's a better way to say it. So when we increase the oxygen levels, it tells the brain to stop breathing. So if you look over here on the right, okay, it's showing you that the receptors become sensitive to the high levels of the PCO2. So that causes an increase in it. But the body doesn't respond because it's sensitive. So in a normal person, that would increase our respirations so that we could blow it off. But it doesn't happen with the COPD. Okay? So their O2 levels start to decrease. And so what's a typical O2 level with someone with COPD? If a normal person had it, we would send them out 911. But with someone with COPD, we accept it. What would be normal?
Is it like 80?
88.
And 92?
92.
Yeah, like 88, 89. That's where most of them run. Some of them can run lower, but that's about normal. Anything below that, we would probably start to get a little more concerned. Okay, for a normal person, though, if they were in the hospital, we wouldn't discharge them if they were under 92 and couldn't maintain it, unless they were going home on oxygen, right? All right, so hypocapnia means we don't have enough carbon dioxide, and this can be caused by breathing too fast, because when you're breathing, you're putting out acid, right? Carbon diacid, that's why I call it diacid, just to help me remember every breath that comes out, I'm getting rid of carbon dioxide, which is an acid. So if I'm breathing fast, acid, acid. Now all this acid's coming off. Okay, I'm losing hydrogen ions. Hydrogen ions are acidic. Okay, so I'm going to become alkalotic. Alkalosis does what to the body? Remember, they both affect the central nervous system, okay? Alkalosis and acidosis affect the central nervous system. So we already know, you already said that acidosis does what to the central nervous system? Depresses it, okay? So what does alkalosis do? What are the symptoms of someone that has alkalosis?
Irritability.
It irritates it, right? Because they have tingling, numbness.
The weakness.
Okay. The gas is exchanging between the alveoli, okay, and the blood. And again, it depends on the partial pressure of those gases. So if you notice, whenever you see PO2 or SPO2, it's written as a partial pressure. That's why that P is in there. Okay. It's just representing part of the pressure that's in that gas. Every gas moves along its gradient independent of each other. That's called Dalton's law. I don't know if they'll ask you about that, but they could. So what does this mean? Oxygen has a pattern. It moves across, and so does carbon dioxide. And one doesn't care about the other. They're both moving along. Skippity-doo-dah, skippity-doo-dah. They're on their way. One is not paying attention to the other. Dalton's law. Okay, now, how's the blood coming in? How's it being exchanged? Where's it going? Okay, so the blood's coming in from the body where?
The right ventricle.
Into the right ventricle, okay? And then it goes from the right ventricle through the tricuspid valve. I remember that because the tricuspid has 3 leaves, okay? And so that's my strong side of my body is my right side. So it comes through that tricuspid valve, and then it goes where?
To the capillaries for the gas exchange.
Okay, so we went from right atrium, superior vena cava, right? Or inferior vena cava, right atrium, through the tricuspid valve into the right ventricle, and from the right ventricle into the
pulmonary.
What? What carries
pulmonary
blood?
Pulmonary artery.
Pulmonary artery into the lungs for that gas exchange. Okay, that's the only artery in the body that carries deoxygenated blood. Now think about where that artery is going. It's going into the lungs. So if that artery backs up or becomes stenotic and doesn't work, where's that blood flow going to back up to?
In the bowel.
To the right side of that heart, right?
Mm-hmm.
That's a cause of right-sided heart failure. So you don't need to know this for now, but you'll be happy I told you this in a couple of weeks. Okay. So if that artery is damaged, that pulmonary artery going into the lungs, or if the person has lung disease, it can affect the right side of that heart. Now, why is that important? Because when we see right-sided heart failure, we need to know the causes of it. And one of them is lung disease. But don't get it mixed up with the symptoms. Because when we talk about symptoms of right-sided versus left-sided, what are symptoms of right-sided heart failure?
Edema.
It's going to affect the what?
The lower extremities.
The body, right?
Body, yeah.
Yeah, the lower extremities, like your belly, your feet. Left-sided heart failure affects what?
The lungs.
The lungs. So you're going to have lung symptoms with left-sided, but it's lung disease that causes right-sided. Just so you know that. All right. You don't need to know about that much. They probably won't even ask you about that. That's really just talking about how the alveoli is, how it's constructed. I already talked to you about that, what you really need to know. Okay. And there's macrophages and stuff in there that help clean up some of the bacteria in that alveoli, but still things can get past those macrophages as well. So that might be the only thing they ask you about. Yes, there are macrophages at that area, and those macrophages, remember, are protective. So they're trying to eat up the bacteria. But no matter everything we do or everything the body does, sometimes bacteria can still get through. Otherwise, people wouldn't get sick. All right, ventilation perfusion ratio. This is how the airflow is in comparison to how it's perfusing the blood. Okay. And it has to match perfectly for gas exchange. So sometimes people will have a ventilation perfusion issue because the ratio is not the same. The problem with that is they're going to have a problem with breathing. So they're likely going to end up on some sort of ventilator to help them. Also, the total surface area available for diffusion matters, because if that total surface area isn't available, then gas exchange isn't going to happen properly. I just talked about this a minute ago. I said if part of the alveolar wall is destroyed, the gas exchange isn't going to happen correctly. And what did I say disease causes that?
Emphysema.
Emphysema. They're going to ask you about that likely at some point, either on the quiz or on the exam. All right. And then fluid accumulation. And I said that happens with what?
Left-sided heart failure.
Okay. Well, heart failure definitely could cause lung congestion, and right-sided heart failure could cause, left-sided heart failure could cause something called pulmonary edema, where the lungs are totally congested with fluid. So yeah, good. That was a good answer. What else?
Pneumonia?
What else can cause fluid? Pneumonia, yes. Pneumonia can cause fluid to develop there. Now, other things that can cause excessive mucus in the lungs are COPD, bronchiectasis, asthma. Any kind of like lung disease can cause excessive mucus because the body's trying to fight it off. And then cystic fibrosis actually blocks the ducts in the lungs, because cystic fibrosis, they have a problem with the genes. And so it causes this thick, sticky mucus. And not only does it plug up the lungs, but it plugs up a lot of other stuff like the pancreas, okay, and other things in the body. So if they have cystic fibrosis, they're really at risk for a lot of lung infections and breathing difficulties. Put yourself on mute, please. All right. So most of your oxygen is going to be bound to hemoglobin. All right. And the hemoglobin brings the oxygen out to the tissue where it delivers the oxygen there. And then once that happens, the hemoglobin would be broken down into different components. It goes back into the body. Now, with someone with sickle cell, I was talking about this, okay? Most of us are born with hemoglobin F. Well, all of us are born with hemoglobin F. Okay, that's fetal hemoglobin. So if a baby has sickle cell, you really won't see the signs of it because they have what we call hemoglobin F, and hemoglobin F is not affected by sickle cell. But when they become about 1 year old, their hemoglobin should convert to hemoglobin A. That's adult hemoglobin. That's what most of us have. Someone with sickle cell has hemoglobin S. And the problem with hemoglobin S is when the hemoglobin releases the oxygen, it breaks down the cell. Now, typically a red blood cell lives 120 days. So a normal red blood cell could normally release a few times oxygen to tissues in the body. It can recirculate and release. But with a sickle cell, it can't do that because what's the lifespan of a sickle cell red blood cell?
120.
Yeah, sickle cell?
20-something days. 20-something days.
10 to 20 days, right?
10 to 20.
10 to 20 days, because when the cell releases the oxygen, it causes the cell to sort of break down. It will become sickled, meaning that it leaks. It develops this crescent shape. It gets stuck in the system. So also with these kids, you'll see pain. Why? Because the blood flow can't get through. And when blood can't get to the cells, it causes what?
The sickle cell crisis.
Okay, but the blood not getting to the cells is called what? If someone's having a heart attack and the blood can't get to the cell, what do we call that?
Oh, infarct.
Ischemic or hypoxemia.
Ischemia. These kids have ischemia throughout the body, which leads to that sickle cell crisis. Okay, what things cause it? Think about it. dehydration, so they don't have enough fluid, and the cells are already sticky and weird shaped and getting stuck. So if they don't have a lot of fluids, it's going to lead to a crisis. If you take them into the mountains, or if you have them running a marathon, the same thing, because the body is starving for that extra oxygen. It can't get it. Okay. Pressure in the atmosphere is going to be higher up in those mountains. All right. So all that is going to affect someone that has sickle cell. Yes.
Is that all because of the shape of the blood cell? That like
Yes.
crescent shape?
Well, it's because of the type of hemoglobin that it is. It's
Okay.
hemoglobin S. So there's a glutamate missing on the amino acids that make up that cell. It's, it can get pretty deep. But because of that cell, the hemoglobin is not normal. The main thing, what you want to know here is that the hemoglobin is not working properly. So when it delivers the oxygen to the cells, it can do that process still, the hemoglobin S. It can bring the oxygen, but the problem is the cell is not going to be any good after that. So we can't reuse it. And the cells start to break down much quicker. Okay. So where do those damaged and old cells go?
Spleen.
Right. So what do you notice in kids that have sickle cell? How's their spleen?
Enlarged.
Enlarged. Why? Because it has all this garbage in it that the body's supposed to be able to process, but it can't process it because the way it's broken down, it's not breaking it down right. Okay. So a lot of things depend on the body's ability to exchange those gases. Okay. Oxygen levels, carbon dioxide levels, temperature, the pH in the blood. So all those things will play a part. All right. And then the carbon dioxide is the waste product from when the cells break down. It can also be reversibly bound to the hemoglobin. Most of it goes into the red blood cells. So that's why we have to get rid of it. Okay. Because it's going to go in the red blood cells then. And we know that it's an acid. Then if we don't get rid of some of it or most of it, then it's going to make us acidotic. Okay. You don't need this stuff. This is diagnostic. We don't care. Oh, we care about that though. Sneezing is just a reflex. Okay. So something tickles your nose that's not supposed to be in there. What happens? Ka-choo. Okay. It helps get rid of the irritant, and it's associated with inflammation or foreign material because you can take stuff in that like pollen and stuff like that then leads to a sinus infection or some other ish. Okay. You can take viruses in, and those could lead to something like a cold. Please put yourself on mute. Coughing can be caused by nasal discharge. What else could cause coughing?
Choking.
Okay. Choking from inflammation or foreign matter in that lower respiratory tract. What else? What is it?
ACE.
Lisinopril, ACE inhibitors. Good. Good. Those ACE inhibitors can cause an irritating cough. And that can be fatiguing and tiresome. And it could cause, rib cages and stuff to become tender, body parts to become tender if someone's not that well and they're constantly coughing. Anything that you inhale. I would know these different sputums, okay, and what they're associated with. They like to ask about these. So yellow-green is going to be infection. Rusty or dark is usually pneumonia. Large amounts of foul, purulent odor. They love this one. That is bronchiectasis. And remember, I said that thick mucus, that's going to be either asthma or cystic fibrosis. Blood tinged, so could be tuberculosis. All right. And then I told you there's two types of ways people can bring up blood. One of them is they can cough it up, and one of them is they can vomit the blood. Okay. If we vomit the blood, what's it called?
Optosis.
Hematemesis. Emesis is vomit, not hemoptysis. Okay. And when we vomit blood, it's usually that grainy, like coffee ground substance. So usually it's associated with some sort of GI bleed. Okay. Hemoptysis, if we cough it up, we got to mop it up. This is coughed up blood. Hemoptysis. We copped it up. We got to mop it up. This is your bright red, frothy sputum. It's usually associated with pulmonary edema. And remember, I said pulmonary edema goes hand in hand with what? So if it's lung symptoms, it's usually what?
We talking about left side of the
Heart
heart.
failure.
Left-sided heart
Yeah.
failure, right? We might see this with TB too. All right. So sometimes the hemoptysis is caused by the pulmonary edema. We might see somebody cough up bright red blood too because the blood vessels there are eroded for some reason. The different breathing patterns that you need to know. So eupnea is normal. They won't ask you about that probably. They might. I would expect that more on a quiz than on the exam, but they could. But the one I would know is Kussmaul's. We talked about that already. I already told you that's associated with acidosis, typically metabolic acidosis, which we see in diabetics type 1 that have really high blood sugars. And they're deep, rapid respirations. They'll usually say something like abnormally deep, or they might give you select all that apply. You know, one of them might be abnormally deep and one of them might be rapid. And then strenuous exercise. Why does that cause an increase in the respirations?
'Cause
Anybody
you're
know?
breathing quicker to get the blood flowing to like perform the action.
No. This has to do with the muscles. So your muscles actually break down and release something called lactic acidosis. It's from anaerobic energy, okay? And you develop something called lactic acidosis, so that can cause a change in your pattern of breathing as well. All right, so if you have any sort of acidosis or alkalosis, or a marked decrease in your oxygen levels, then your body is going to respond. Typically, your chemoreceptors respond first, okay, in your carotid arteries and all that. Then your lungs are going to respond secondly, and then your kidneys last if your lungs aren't able to correct it. So in metabolic acidosis, we've already gotten to that point. The lungs weren't able to correct it. Now the kidneys are going to kick in and try to help correct this. Breathing patterns. So labored respiration, prolonged expiration. These are usually some sort of obstruction in the airway. So who do you see that with? Your COPDers, maybe people with asthma. Wheezing or whistling sounds, those are usually obstruction. And stridor, they like to ask about. That's a medical emergency. Okay. That's going to be a high pitched noise. It usually happens with upper airway obstruction. We can see this in kids, usually in kids with croup, or your book calls it laryngo, tracheo, bronchitis, I think. Okay. That is something that we will typically see with young kids. And when I say young, I'm saying like maybe 1 to 2 years old. You might see it in a 3-year-old. You might see it in kids a little bit older if they have some issue like cerebral palsy or cystic fibrosis. So why cerebral palsy? Because a lot of times it's not that affects the lungs so much, but because of the lack of movement, sometimes they'll develop problems. But with cystic fibrosis, it's different because they have that thickness of that mucus. Okay. And that thick mucus could block that upper airway. Somebody with asthma, okay, or someone with an infection that's producing a lot of mucus for some reason. Maybe they have COPD and they have pneumonia and they're producing this sputum. And you've heard of mucus plugs, right? Sometimes you're suctioning someone and a mucus plug can get stuck in that airway. And that could cause that stridor. Again, that's going to be a medical emergency because the airway is blocked. On this, what do you want to know? Okay, we already talked about eupia. That's normal. Tachypnea is always going to be faster. Bradypnea slower. Apnea, they're not breathing at all. Okay, so like most people, if they stop breathing with like babies, when we look at apnea, usually 15 to 20-second pause is normal. Anything above that, we have a problem. Okay, hyperapnea, that's increased depth of respiration. So they're breathing too fast. So you might see that in someone with respiratory with hyperventilation. Cheney-Stokes, we call that the death rattle. Okay, you ever seen somebody dying, especially like a hospice patient? You'll hear this, and they'll have periodic breathing with periods where the breathing stops. So periods of apnea. Okay, and then the breathing will speed up and then slow down. And then Kussmaul's. Okay, so those are the ones I expect them to ask you about. Kussmaul's, Cheney-Stokes, apnea. The other ones are pretty much self-explanatory. The eupnea, the tachypnea, the bradypnea, right? You should know those. And then what's the difference between the breath sounds? Okay, rels are usually going to be with some sort of secretions. So usually we'll ask people, when you hear that, hey, give me a little cough. And a lot of times if they cough, it'll go away. Bronchi is going to be a deeper cough, and usually they have thicker mucus. And you're usually going to see this more with someone that has like some sort of pneumonia or bronchitis. And then if you don't hear any lung sounds, then we probably have a collapsed lung. That's why you got to know your sounds. You got to be able to hear it. Make sure you're doing a thorough lung assessment. If you really want to know how to do one, watch Nurse Sarah. She has a great one. She goes through all the points, talks about everything. Shortness of breath. Okay. So dyspnea is shortness of breath. And this can be caused because, as someone mentioned earlier, if I have too much carbon dioxide in my blood, what am I going to feel like? And they said hypoxic. Okay. Because the carbon dioxide is going to take the place of the oxygen. All right. Or they can have hypoxemia, which means that their hypoxia is in where? Or their lack of oxygen.
In their blood.
Blood.
Okay. So we could see this on exertion or when they're climbing stairs. When it's bad is when we see it what? What's the other way we say this? We say dyspnea, or we call it dyspnea at
rest.
rest.
Yes.
Okay, that's worse, right? Because they're not doing anything and they're short of breath. Because when you're moving, you need a little more oxygen. So we can understand why sometimes their levels might decrease. But now if it's decreasing when they're just sitting, that's an issue. All right, so what will we see? Flaring of the nostrils, using of those accessory muscles. The nostrils are very evident, especially in babies. And also those accessory muscles. If you're doing babies, like, I used to do babies that have respiratory problems, you could see this so easily. You could just see the rib cages sucking in around the sternal muscle, up around the neck. You can see the areas sucking in. And if they have tracheomalacia, you could actually see that whole area sucking in when they're in respiratory distress. Orthopnea, we're going to see that when they're laying down, and that's usually because of pulmonary congestion. Again, we go back to left-sided heart failure. Okay, blood's backing up into the lungs, and that causes that pulmonary congestion. Other things that could cause it are pneumonia. The cystic fibrosis is definitely going to cause some kind of congestion in the lungs. Paroxysmal nocturnal dyspnea, I would know this. I would expect them to ask you about this. This is when they wake up in the middle of the night and they can't breathe, okay? Shortness of breath. It's acute. And again, look at who we see it in. Left-sided heart failure. Cyanosis. This is when we have bluing of the skin and the mucous membranes. Now, you'll see this in kids who have something called tetralogy of Fallot. Okay, they have 4 defects in their heart. They have a ventral septal defect. They have pulmonary stenosis. They have right ventricular hypertrophy, and they let's see, and they have an overriding aorta. So because of those 4 defects in the heart, it causes unoxygenated blood to mix with oxygenated blood. So these kids will look blue, and it's considered a cyanotic condition. All right, so you'll see blue coloring of the skin, blue coloring of those mucous membranes. And you might see this in anybody who has a condition where we have unoxygenated blood circulating in the normal bloodstream. Pleural pain, this is going to be that sac that's around your lungs. That sac that's supposed to let your lungs glide back and forth and move. And it becomes inflamed, or you get an infection in there for some reason. And it can cause what we call a friction rub. Usually we'll have the client sit forward, and that can help relieve some of that pain. But it's because they're rubbing together. You can actually hear the sound, if you listen, of that rubbing. And it can either be rough, inflamed, or scarred. And then club fingers, okay? Club fingers are only going to come with long-term diseases. So who do we typically see these in?
COPD.
Okay. Mostly like your Down syndrome clients, people that were born with some sort of hypoxic issue, and they've lived that way for their life. That's who you really see them in. But you will see changes in people that have things like emphysema and COPD. One change we'll see in emphysema is the shape of the chest. It becomes barreled. Why? Because there's air in there that is not escaping and is built up, and it's changed the shape of that chest. Okay, again, hypoxemia, too much oxygen in the blood. Hypercapnia, too much carbon dioxide. Therapy, we don't care about. All right, so upper respiratory tract infections. The cold, why? It's in your nasal area, right? Sinuses, again, in your upper nasal and around your eyes. They get puffy. Sometimes you can get bacteria in there because of either a cold that you recently had or exposure to pollen or something else that's got the sinuses inflamed. Even things like cigarette smoking can do it sometimes. Epiglottitis, this is where the epiglottis and the larynx become inflamed. This is a medical emergency. Okay, you're going to see like a big red ball back there. This is life-threatening. And these kids, we're going to talk about it in a few minutes about how they present. And in this disease, you never stick anything in the mouth because it can cause them to go into a spasm and die, close the throat up completely. Influenza, there are multiple types of the flu. This is why we really can't create a vaccine for it, because we have different strains, and the strains will constantly mutate. So no matter what they build up off of this, they still end up with another strain of the flu, no matter what immunization they try to build for it. Scarlet fever, this is usually strep A, beta hemolytic, I believe, and they're going to have like a strawberry tongue. You want to know about scarlet fever, okay? It's a respiratory infection, and they will probably ask you about that with that strawberry tongue, because the endotoxins in the bacteria there cause that tongue to look a certain way when they get it. All right, so common cold is viral, spread through droplets. Hand washing is the best. They can get a bacterial infection, okay? If they do, then we would see additional symptoms. All right, so they're going to be congested nasally, but it's just watery. There's no any kind of discharge associated with it. No green, no yellow, none of that. It's just a watery discharge because it's viral. There's no real infection here, but it could develop into an infection, okay? And it could lead to pharyngitis, laryngitis, or bronchitis if the person continues to have this cold, okay? Or depending on if they got some other bacterial or something secondarily because of this congestion that they're having. We don't care about treatment. Okay, so in any common cold or flu, the virus gets into the mucosa, okay, the mucosa of that respiratory system, and that allows it to get into the tissues. Depending on how bad, okay, what's happening there. So if it's just a cold, it's just going to run its course. It's self-limiting and it'll be gone. But if you get an infection like the flu, okay, then it can lead to some other damage. All right. So it can lead to congestion. It can lead to ear infections, because when they blow their nose and they close the nose to blow it, the bacteria shoots to the back of the throat, or it could shoot up into the sinuses. So people blow their nose, they really blow it hard. What do? They take their tissue, they stick it over their nose, and they blow, and at the same time they're kind of squeezing the nose, right? So that bacteria can flow backwards and go up into the ears, into the sinuses, or into the lungs, and lead to things like ear infection, sinusitis, or pneumonia. Sometimes the resident flora itself can cause a bacterial infection, because you had the virus damaged the mucosa, caused some sort of necrosis there, and that allowed the bacteria to get in and invade that area. So you'll know, because these people are going to present with purulent exudate, and now you know that they have an actual infection and not just a runny nose and a headache. All right, sinusitis is usually bacterial. Laryngotracheobronchitis, that's croup. I just talked about that. That's a viral infection, and it's usually caused by parainfluenza or adenovirus. It's usually self-limiting. So usually these kids, we can take care of them. What we'll do is bring them into like a cool area in the bathroom, run some water, and let that moist air. We don't put them in the shower. We let the air in there like steam up, okay? Or we'll open up a little window in the bedroom, try to let some of that air in. Sometimes that can help them, but it's that moist, cool air, usually what your book talks about, that helps them. And the thing is, it can be self-limiting. On rare occasions, they can develop an upper airway obstruction. And if that happens, we call it, what do we call it? Upper airway infection.
RSV.
I mean obstruction, upper airway obstruction. My bad. What's the upper airway obstruction called? Stridor, remember? Stridor? What's it sound like?
High
High
pitch.
pitch and ash sound.
Okay. And then if they develop that, then it would be an emergency. Okay. But typically we're able to correct this in the home just by doing a few measures. And really it's that cool, moist air. That's what they're going to talk about. All right. So here you have the three that I expect them to ask you about. Laryngotracheobronchitis, that's croup. Epiglottitis, we just talked about that. We'll talk about it more. And bronchiolitis, which is RSV. It's just a fancy name for it. Okay? Don't get it mixed up with bronchiostasias. This is bronchiolitis. It's RSV. It's viral. This is going to obstruct the small passageways, cause inflammation in those little bronchioles. We're seeing this in a lot of adults now. But a lot of times we were just seeing this in infants, 2 to 12 months old. All right, so it comes on slowly, RSV. It causes increase in shortness of breath. Why? Because it's obstructing and causing inflammation of the bronchioles and the passageways. So we'll see coughing, wheezing, retractions, nasal flaring. With the laryngotracheobronchitis or the croup, that's usually from 3 months to 3 years. It's a virus. Here you have inflammation of the mucosa of the larynx and the trachea. It's gradual. And they'll have that hoarse barking cough. It sounds like a seal. If you've ever heard it, it sounds just like a seal. Child will be restless. and they have inspiratory stridor, and it can turn into a medical emergency, but it's usually able to be treated easily by the parents. And epiglottitis, this is a medical emergency. Now, for RSV, they're probably going to end up in the hospital, admitted, okay? And they're going to be in a private room more than likely, unless you can't accommodate that. Then they might put 2 kids in the same room that if they both have RSV. But usually these babies you see isolated in a single room. Epiglottitis, this is 3 to 7 years old, and it's caused by Haemophilus influenza. And here you have supraglottic inflammation, swelling of the epiglottis. It obstructs the airway, and it comes on rapidly. Now, these kids are going to be tripoding, meaning they're sitting Indian style and bending forward, all right, right over their lap. And they'll have drooling, shortness of breath, anxiety, because they're scared. They're scared to swallow. Respirations and pulse will be fast, and they're having difficulty breathing. The drooling is because they're scared to swallow, but they also have difficulty swallowing. Why? Because the whole epiglottis and that area there, larynx, is all swollen. When you look in the throat, which if they open their mouth and you can see in the throat, that's fine, but you don't stick anything in that mouth. The back of the throat will look like a giant red ball. That's a key term they use too to test you. All right, so epiglottis, acute, kids 3 to 7, Haemophilus influenza type B, rapid onset, tripoding, drooling, difficulty swallowing, heightened anxiety. All right, swelling of the larynx, supraglottic area, epiglottis. This can obstruct the airway. It's an emergency. Influenza, 3 types, A, B, C. Again, these mutate, sudden onset. It's viral, so, fluids. That's how we're going to treat it, fluids. They might give you a pill if you're within a certain time period. Otherwise, fluids and rest. Okay? On cue with the fever, fluids. Why do we need fluids? Fever. Maybe it'll help you remember that. Fatigue, aching pains in the body. So, somebody got the flu. What do they say? I feel like I got hit by a truck. This could lead to viral pneumonia or bacterial pneumonia if someone is immunocompromised. Otherwise, they're just going to have the flu and be over it. Scarlet fever. Okay? Group A, B, hemolytic strep. They'll have the strawberry tongue, the sore throat, the fever. Again, what you're looking for is what makes it stick out. So for the flu, remember, it's viral. There's different strains. For this, it's AB hemolytic. It's that strawberry tongue. Fever, sore throat, chills, vomiting. But that strawberry tongue kind of sticks out because of those endotoxins being released. Sorry, exotoxins. All right, there's that tongue. All right, lower respiratory tract infections. These are going to be like bronchiolitis. That's RSV, remember. Pneumonia, SARS, COVID-19. I haven't really seen any questions too much on those two. TB, they're definitely going to ask you about. And histoplasmosis, that comes from bat and bird droppings. That's mostly in your AIDS patients because that attacks people that are immunocompromised. And then anthrax, which comes from the soil. We saw this scare at the post office. That can be inhaled through the skin. If you're in the soil where it is, it can be inhaled through the nose, nasally. That's what we saw at the post office. There was a powder. They inhaled it. And it can also come in your GI tract. So if a cow or beef were contaminated, you might get it that way. All right, bronchiolitis, again, RSV, transmitted by oral droplets. I would know that. It causes necrosis. Remember, this affects the small bronchi and the bronchioles. So they're going to have wheezing, shortness of breath, cough, chest retractions. Pneumonia. This can be viral, bacterial, or fungal, and it can happen in both lungs or in one. Pathological changes are going to be changes with the interstitial tissue, depending on what kind of, pneumonia that you have. The alveoli can be affected also, and you can get it from the hospital, nosocomial, or healthy people sometimes get it out in the community because someone else has it and they get it that way. I would know the two that they typically ask about are the lobar and the interstitial or the atypical pneumonia. So the differences are with the lobar, it could be in any or all of the lobes. It affects the alveolar wall, okay, causes fibrin, cell leaking. These people are going to have high fever. It's going to come on quick. High fever, rusty sputum, and those rales. That's that fluid. Also, people with pneumonia, the bacteria and the fluid tend to get in there and become consolidated. So a lot of times with pneumonia, they're going to have dull lung sounds. What does a person with regular lungs sound like? What's that called?
Doesn't it sound like air passing through?
What's it called?
Oh,
Eupnea?
eupnea.
No, that's a type of breathing.
Adventitious.
Adventitious means what? No adventitious lung sounds means what?
Is it vesicular?
No, restaurant.
So you might hear them say vesicular, but vesicular is talking to a specific area. Okay? So what we're going to hear is resonant or hyperresonant lung sounds. Okay? Hyper, who would you hear that in?
Asthma.
Probably more like emphysema, because remember I said they have that air trapped. So resonance is the normal low pitch sound that you hear when you percuss a healthy chest that's filled with air. Okay. When you hear dullness, then usually we consider that some sort of fluid in the lungs, but a lot of times that's pneumonia because it's more of a consolidated sound. And that indicates density, okay? Or sometimes it can be from a tumor too. Hyperresonance means we have too much air in the lungs. So usually that's you're going to see with somebody that has something like emphysema because of that air trapping. Or you might see it if they have like some sort of effusion. You should know your different lung sounds because when you're doing lung sounds, okay, on a person, you have to describe them in your notes. All right. So again, let me just tell you clinically, okay, pneumonia or consolidation is going to have that dull sound when you percuss. COPD and emphysema is going to have that hyperrenaissance because of that trapped air in there. A pleural effusion would also give a dull sound because with the pleural effusion, you're going to have fluid. And then a pneumothorax, that's air, right? Air in the lung. So that's going to be hyperrenaissance. So you see how these different sounds can tell you what's happening within the lungs. All right. Atypical or primary atypical pneumonia. This is where we have scattered small patches of pneumonia throughout the lungs. Okay. And it affects the interstitial area, especially around the alveoli. Usually this is going to come on not as quickly. It could come on quickly, but it varies with different people. Notice with your lobar pneumonia, you have that productive cough with rusty sputum. You have high fever and chills. Okay. With this one, you're going to have a non-productive cough. The muscles will be a little bit achy. And they may or may not have a fever. All right, bacteria, that's community-based. So a lot of times we'll see that in young, healthy people. Again, the exudate is going to have fibrin in it. So that makes it a consolidated area in that alveoli. Okay, because that's where the exudate forms, in that alveoli. So now that gas exchange can't take place the way it's supposed to. And also it can produce that rusty colored sputum. So sometimes in bacterial pneumonia, when they cough up, you'll notice that that sputum has a little bit of a pink tinge to it. Okay. They can also get an infection in the pleural cavity, and that's called empyema. I would know that. Okay. The infection in the pleural cavity is known as empyema. All right. So again, I just talked about most of this, but just remember, what are the manifestations going to be? So with lobar, it's going to be a quick onset, high fever, chills, pleural pain, rels, rusty colored sputum. And because it's affecting the gas exchange, we have confusion and disorientation. I would know this one, Legionnaires. Okay, this is caused by Legionella pneumophilia. We usually see this in environments where the plumbing is leaking, or maybe an air conditioning unit is inside an enclosed area and the back of it is leaking. Okay, this can be considered nosocomial because they can get it in the hospital. It's hard to identify because they need a special culture to grow it in. If they don't treat it, it can kill someone. It causes congestion, consolidation, and necrosis in the lungs. So you'll see this like on cruise ships, in hospitals that are older. Atypical pneumonia. This is caused by this mycoplasma bacteria. All right. And then for this one, okay, it's unproductive cough, hoarseness. Again, you can see it's a little bit different. If they do get it virally, usually it's from the flu or from RSV. Unproductive cough, that's the key for this one, right? And you don't really see those spiking fevers like you do with the other one. Pneumocystis carinii, this is your AIDS pneumonia. This is usually what kills them. So it's an opportunistic infection, believed to be inhaled. It causes interstitial inflammation. So what does that mean? In that lungs, where that necrosis and that interstitial inflammation occurs, is going to become fibrotic. Okay? So what does that mean? You know how when you go to McDonald's and you order that nice shake, if the shake machine ain't broke? So you got that nice chocolate shake, you're about to drink it, right? And they give you that damn paper straw. So at first you put the straw in there and you get a couple sips and it's good, man. And now you're addicted to it. You want some more, but what happens?
The straw starts to
The straw fail.
fails itself and close in on itself.
Right. So now it's like you're sucking what? Nada. You're not getting anything, right? You're just sucking, but nothing's happening. So this is what someone feels like when they have a problem with the interstitial area in the lung, because it becomes fibrotic. And so it's like they're trying to breathe through this mess in the lungs that's not producing much in the way of gas exchange. Okay. Because fibrotic tissue does not work. So wherever that fibrosis and that necrosis is, there's no gas exchange happening there. So the lungs will still push the blood out to some of the areas where gas exchange can occur. It'll search and try to get to those areas, but the amount of air or gas exchange that's going to take place is going to be significantly decreased. So what do we see? Difficulty breathing and a non-productive cough. SARS, okay, this is coronavirus, respiratory droplets. You guys should be pretty familiar with the symptoms here. Headache, fever, anorexia, diarrhea. Again, the lungs are going to be affected here, and they'll have a dry cough with marked dyspnea or shortness of breath. Again, that interstitial area is congested here. So if we can clear it up, get rid of the viral infection, eventually, the lungs will go back to pretty well normal. But these clients can end up on mechanical ventilation. Again, it's going to depend on what was their situation when they acquired the infection. Because if you or I got this, we might be okay. But what about someone who's compromised in some other way? Now, think about your lupus people, because that affects your lungs. Think about your cystic fibrosis people. How about your COPDers, your people with emphysema? How's this going to affect somebody like that? COVID-19, also SARS, okay? Again, rapid damage to the lung cells, and it causes cytokine storm. So what does that mean? All right. Again, I had a friend who got COVID-19. He died from it because he was 32 years old, by the way. He had lupus, okay? Systemic lupus erythematosus. And he had this COVID, and in the middle of the night, he ended up with this cytokine storm. So the body actually is trying to fight the infection, but it's overworking, and it's over fighting the infection. Okay. So it's sending all these things out, these little interleukins, okay, to fight this reaction in the body, but it's overdoing it. And eventually it can cause them to end up either on a respirator. He died from it because he coded twice. He coded the first night, they brought him back. He coded the second night, they couldn't help him. So what else are you going to see? Fever, chills, coughing, sneezing, difficulty breathing, all the things of COVID. You guys know, you should be very familiar with the signs and symptoms of that. And I really haven't seen them ask too many questions about COVID. Most of the stuff that they're asking about, TB, they're definitely going to ask you about, okay? So TB is Mycobacterium tuberculosis. It's an acid-fast bacteria. And they're saying oral droplets, but it's considered airborne, okay? Why? Because those droplets, the way they travel and explode and expose you, happens to people in crowded places, immunodeficiency, malnutrition, alcohol. But the biggest thing that we're seeing right now, and I expect them to ask you something about this, the rise of the TB right now, because as infection control officer for years, I didn't have to monitor for TB. The rates were really low. We weren't even monitoring for it. Now that's changed because of HIV. Okay, HIV is putting them at risk for these other infections. Why? What does HIV do? It attacks your T4 cells. Your T4 cells are responsible for immunity. Okay, so without those, your body can't fight infection. So patho M tuberculosis, it's resistant. So if it lands on the counter and you touch it, you could get it. It survives for a long time. The neutrophils in your body, what do?
Eat off the bacteria or try and
The infection.
So their job, they're the first cells to respond to infection. But you see here, it doesn't happen. Now, cell-mediated immunity, right? You don't usually need exposure for cell-mediated, right? That's your T cells, right?
Yeah.
We need exposure for humoral, right? For those B cells, but usually not for the T cells. This primarily affects your lungs and your other organs. So how's it going to affect your lungs? In your lungs, you're going to develop something called granulomas. I would know that. And tubercules. So that's why we can do a chest x-ray. We can see those granulomas and those tuberculosis. And they're going to develop like necrosis inside, something called caseosis necrosis. And that's like this cheesy, like substance that develops in the lungs. It's part of the infection. So primary infection, usually the person doesn't have any symptoms. The organ enters the lungs, the macrophages will gulf it up, okay? If for some reason you don't have cell-mediated immunity, which would be who? Who did I
The
just
T cells?
say? Who did I just say doesn't have
HIV,
cell-mediated immunity?
T cells.
AIDS.
HIV. Okay. Then right away that bacteria can reproduce and start to destroy the lung, and it can be contagious. But most of us have cell immunity, cell-mediated immunity, right? So for most people, this doesn't happen. But if someone didn't have cell-mediated immunity, then it could go right to their lung and be contagious. For most people, that first infection is going to be asymptomatic. And if they have cell-mediated immunity, it's going to go in the body and lie dormant. So they might feel a little flu-like, and then it goes away. Now it lays dormant in the body, okay? Now they get this secondary or this reinfection. So you know how many people have ever tested positive? Just think in your mind if you've tested positive for TB exposure. You've never felt sick. You didn't even know that you were going to test positive for it. But you went in and they said you were exposed to somebody with TB. So from now on, you can't get a PPD. Okay, that would happen if you had the BGV vaccine, but it would also happen if you were exposed to TB. But you never felt sick. You never got sick. But one day, your cell-mediated immunity, those T cells are impaired because of stress, malnutrition, an HIV infection, or because you're aging. So now that microbacteria starts to reproduce and infect the lung, and you develop active TB, and now you can give it to somebody else. Active stage signs: anorexia, malaise, fatigue. Your big ones are going to be weight loss, low-grade fever, and night sweats. That's huge. A cough that's prolonged, and usually it's productive. So remember I talked about that lung cavitation, those granulomas? That's going to start to develop. The sputum is going to become purulent now, and it contains blood. So now one of the ways we can detect TB is take a couple of sputum tests, right? 2 positives equal TB, right? If your cell-mediated immunity is working, all right, some of the bacilli are going to go to those lymph nodes. That granuloma is going to form a tubercle. I would know that. Okay, the tubercle can be seen on those chest x-rays. And again, this can stay dormant for a long time. But if your immunity drops for some reason, then it can pop out. But as long as your immune response is high, your resistance is high, you may not develop any symptoms for a long time. All right, so primary or latent, you've been exposed and infected, but you don't have the disease and you're not symptomatic. At that point, you can't transmit the disease. But if you develop that second or that active stage, or if you have something like HIV infection current already and your T cells aren't working, in those cases, you could be contagious. Got it? I haven't seen them ask about this, but this is miliary or extrapulmonary, and this is a progressive form. We see this in kids under the age of 5 usually. Okay. It's not contagious if the lesions are not found in the lungs. And they'll have a couple of similar symptoms, like the weight loss, failure to thrive. So for kids, we're talking about they're not growing. Their body's not on that growth spectrum the way we expect it to. That's what failure to thrive means. And then other infections, they can develop secondary infections as well. All right, so the active TB, the organism's there. It's causing those cavitations or those large open areas in the lungs. The cavitation could go into other areas of the lung. All right, and these people will have a cough, a positive sputum. Again, that's usually what we check is that sputum. Got to get a couple of them. And it's highly infectious, okay, during this time. Isoniazid. That's what I was trying to think of the other day. Okay, because these drugs are terrible. The red one, the R ones cause everything in your body to look like blood. The isoniazid, it causes things like neuropathy. Some of those other ones cause damage to the body too. And most people that have TB have to take 4 or 5 of those drugs together. We call that HART, highly active retroviral treatment. So the drugs for people that have TB now don't work that well. And that's a little scary. All right, histoplasmosis, this is fungal. And again, it comes from those bat droppings or those bird droppings. And of course, a lot of that falls into the soil. So the spores there, if you were someone with AIDS or HIV, you could get this. Also, if you're a farmer or someone that's working in the soil, even just planting vegetables, okay? It's an opportunistic infection, though. It's usually going to get somebody who's immunosuppression. Okay, their immunity system is not working. The first stage is usually asymptomatic. They can also develop some similar symptoms to the TB because they can develop those granulomas, the cough, the fatigue, the fever. How would you separate this one? It's opportunistic for one. Okay, TB is not. TB will hit anybody. Okay, also caused by the bird droppings or the bat droppings if they ask you about it. And the histoplasma capsulatum. Remember that this one is fungal, so we're likely going to get it from inhaling like a spore or a dust particle, whereas TB, you would get that from the oral droplets, even though it's airborne. Someone would be talking or coughing or singing, and those droplets would come out of their mouth and end up in your body somehow. That's how you're going to get it. For this, you don't need any droplets. This is going to come from the dirt or dust or somewhere along that way because it's some kind of bird poop or bat poop. That's what it means when I talk about droppings. Everybody got that? Anthrax, this is bacterial infection by gram-positive bacilli. The spores can live for a long time. So this is in the soil right here in America. And some people have it on, they have this stored. Okay. The government has this stored. So do other governments for biological warfare. This can get in through the skin, through the respiratory tract or digestive tract. So remember I said you can get it through your skin, you can inhale it, or you can swallow it. It's going to affect you differently. So if it comes in through your skin, it's going to cause blisters, sores. If you inhale it, then we're going to see things associated with the lungs, plus fever, chills. All the top ones, except for fever and chills, are associated with the lungs, right? Chest discomfort, shortness of breath, confusion. Obviously, if you have shortness of breath, you can have confusion, okay? And then some other ones, headaches, sweats, tiredness. They'll probably stick to these ones up here. GI, what will we see? Again, we're talking about swallowing it. So it's going to affect the throat. And then when it gets into the GI system itself, nausea, vomiting, bloody diarrhea, swelling of the abdomen. Obstructive. So this is going to be like your cystic fibrosis, your lung cancers, your aspiration pneumonia. You need to know what aspiration pneumonia is. How does it affect the lungs? They're going to ask you about that. Obstructive sleep apnea and asthma. So cystic fibrosis, again, this is genetic. So if if they ask you how do people get it, genetic. The gene is damaged. Okay. And they develop this thick, sticky mucus from the exocrine glands. So it's going to affect the lungs and the pancreas. The mucus obstructs the airflow in those bronchioles and those small bronchi, causes damage to the bronchial walls and common infections. In the digestive tract, the first sign of this is a meconium ileus in the newborn. So what that means is when the baby comes out, it's supposed to poop within 24 hours. These babies don't. And their pancreatic ducts are going to be blocked. Their bile ducts are going to be blocked. This all has to do with digestion. Okay. And salivary glands, which you also need for digestion because those are producing those salivary enzymes that you need to start breaking the food down. Please put yourself on mute.
Yeah.
Who's talking? Can you put yourself on mute, please? All right. It can also affect reproductive tract. So male and female can become sterile. Okay. So for men, the vas deferens, that transports that sperm. Okay. And it's that mature sperm that's coming from P. Diddy's house. Okay. And it can't move through that vas deferens the way it's supposed to be transported. So males will be have a problem with sterility. They won't be able to reproduce. With women, it obstructs the cervix, so it blocks these fallopian tubes, and the eggs can't get through. All right, and the sweat glands. So back in the day, doctors would kiss the baby on the skin, and they could taste the saltiness on the skin. And this is how they would know that the baby's had cystic fibrosis, because the sweat is real salty on these kids. All right. So again, signs and symptoms: lack of that meconium ileus. That's the first poop. Salty skin. Malabsorption. So again, the pancreas isn't working. The pancreas produces what we need to break down fats in the jejunum. Also the bile, okay, from the gallbladder. So those two are breaking down the fats. In this baby, they're not working. It's blocked. So that's going to cause steatorrhea, which is a fatty, greasy looking stool, and abdominal distension because the body is not absorbing. So abdominal distension, if you ever seen little kids from overseas that don't eat, what's their belly look like? Is it
Big.
skinny?
Oh, big.
It's big.
Yeah, it looks like they got a little baby in there, right? It'll be, bloated. It's abdominal distension because they have malabsorption. They're not getting enough of what they need. And then chronic cough, frequent respiratory infections. Why? Because those little bronchioles are plugged up with mucus. Remember, I said it's damaging the wall there too. And these babies can't meet the normal growth milestones. Why? Malabsorption. So with these babies, usually one of the things that you're doing is putting enzymes, pancreatic enzymes, in their food so that their body can break down the fats and they can absorb what they need to. Genetic testing, why? That's how they get it. All right, lung cancer, most related to smoking. It's one of the most common types of cancer. Bronchiogenic is malignant. That means it's going to spread. And it comes from the bronchial epithelium. Squamous cell usually develops from the epithelial lining of the bronchus. And then you have adenocarcinomas and bronchoalveolar. Those are harder to find because they usually grow on the periphery or the sides of the lung. All right. The problem with the lung tumor is it obstructs the airflow into the bronchiole. That causes abnormal breathing, dyspnea, or shortness of breath. It also can cause erosion of the vessels there. And so that can cause bleeding and inflammation, coughing, and hemoptysis from the erosion of those vessels. And then secondary infections. They can also develop things like pleural effusion, so that pleural sac is affected, hemothorax, where they have bleeding now into the lungs, or pneumothorax, where they have this air pocket. Paraneoplastic syndrome. Okay, let me tell you about this. So small lung cell cancer is the worst lung cell cancer you can have. And people will develop small lung cell cancer. Paraneoplastic syndrome means the tumor from that cancer is secreting hormones that it shouldn't be. So remember, we talked about ADH, antidiuretic hormone. These people develop SIADH. Okay, because the small lung cell cancer, the tumor releases ADH. It causes the release of that ADH. So a lot of these people, this is one of the most common causes of SIADH. That paraneoplastic syndrome is when the tumor cell secretes the hormone or hormone-like substance that causes some other change in the body. Okay? So you need to know what paraneoplastic syndrome is. And that is when the cell of the tumor starts to secrete hormones or a hormone-like substance, and it causes changes in the person's body. Signs and symptoms of lung cancer. So, persistent productive cough. We can see it on the x-ray. They're coughing up blood, hemoptysis. He coughed it up. We got to mop it up. Involvement of the pleural lining of the lungs. Chest pain, hoarseness, facial or arm edema, headache, dysphagia, or atelectasis. So depending on where the tumor is growing, how's it going to affect us? So systemic signs for this type of cancer are going to be weight loss, anemia, and fatigue. And then that paraneoplastic syndrome, okay? Again, it depends on what hormones secreted. So for small lung cell cancer, it's usually ADH, but also sometimes these tumors can cause secretion of things like steroids, corticosteroids. Okay, in that case, you're going to see Cushing's syndrome, where they have the round moon-like face, the big belly, the skinny legs, and it also affects their blood pressure, their blood sugars. And then signs of metastasis are going to be bone pain. And of course, if it's affecting the lung, it's affecting the oxygenation, we can see cognitive deficits and some motor deficits. Aspiration, you got to know this. How's it going to affect the lungs? And is it different if it's fluid versus solid? So any food, fluid, emesis, or other foreign material that's sucked into the trachea and the lung. Okay, so sometimes people aspirate because they vomit. They're laying backwards, they vomit, it goes back down. Or they drown and they swallowed some fluid. Or they're just eating and they choke. Okay, and the choke could be from some fluid, especially if they have a swallowing disorder, or it could be from the solid material itself. It happens a lot with young children or people that lay down when they eat or drink. And so this can cause obstruction because aspirate itself is a solid object. Inflammation and swelling because the aspirate is an irritating liquid. And this is what they're going to ask you. If they aspirate on a solid object, it would cause obstruction. If they aspirate on a liquid, it would cause irritation, inflammation, and swelling, which will also lead to what? If it gets severe?
Obstruction.
Obstruction. All right. And it puts them at risk for pneumonia. All right. So complications of aspiration are going to be aspiration pneumonia. And here the gas diffusion is going to be impaired. We're going to have inflammation or respiratory distress. Okay. They can develop abscesses. And if they aspirate the material and they become absorbed in the blood, we can see systemic effects. So signs and symptoms, coughing and choking with shortness of breath. A lot of times they lose their voice, so they'll grab their throat. especially if there's a total obstruction. Stridor is what?
High pitch sounds.
And it's an upper airway obstruction. Those two things you have
Gotcha.
to know. High pitched sounds, upper airway obstruction. Okay. So stridor and hoarseness, wheezing. Wheezing you'll usually see with the liquids that are aspirated. And then, of course, it's going to affect their breathing and their heart. So tachycardia, tachypnea. What other signs would you see in respiratory distress? Chest retractions, nasal flaring, and they can go into cardiac or respiratory arrest. Obstructive sleep apnea. So here, the pharyngeal tissue is collapsing during sleep, and it causes them to stop breathing. Men are affected more often than women, and if they're overweight or older, it puts them at a higher risk. Asthma, this is bronchial obstruction. So this can happen from someone that has a hypersensitive or a hyper-responsive airway. Most of the time, if people have regular asthma, we'll see this early childhood, okay? If they don't, they can have an adult onset. I was just looking for something there. All right, and so in childhood, it'll usually happen to exposures to things like cold, exercise, cigarette smoke, pollen. With adults, when they have this asthma, and it's usually because I had it one time in asthma attack when I had COVID, and it's because I had a lot of mucus that blocked the airway, and it caused me to develop an asthma attack. But I don't have asthma, so it was like a one-time incident. So intrinsic asthma, okay, is non-allergic asthma. And that is the one that you'll see in the adults because something else happened that caused them to have this attack. Extrinsic is going to be what we usually see in kids that have allergies. Okay. So it's triggered by things like pollen, pet dander, mold. I would know the difference between the two of those. So when you think about it, think about extrinsic. It's triggered by something, in the air, some kind of mold, something like that. And that's mostly in your kids. You see it young and they continue to have it as they get older. Some kids outgrow it, most don't. Or the adult onset, which is the intrinsic, and that's usually some other sort of trigger. Okay. They don't really have asthma all the time. They were just sick or stressed, and something triggered this one episode. Okay, so extrinsic is going to be a type 1 hypersensitivity. Type 1 is always usually allergies, mold, pollen. Intrinsic is going to be adulthood, hyper-responsive tissue, and usually it's cold, cigarettes, exercise, something brings it on. All right, so what's going to happen with the asthma? It changes the bronchi and the bronchioles. We call this remodeling, okay, of the airway. And over time, it can change the way those airways are. Inflammation of the mucosa with edema is going to occur here. We're going to have bronchoconstriction because of contraction of the smooth muscle. Remember, I said smooth muscle always causes an action. So here's an example of it right here. The smooth muscle is leading to the bronchoconstriction. So that's why, what do we give first? Do we give the SABA or do we give the corticosteroid? What's a SABA? Who did my asthma thing?
Short acting anti. I don't know.
Okay, so what does that do?
It's losing the secretion.
It
And
opens
the
the
airway.
airway. So you're going to give that albuterol first and then your steroid, right? Because you need the bronchodilation to occur first, and then we give the steroid to try to decrease. All right. Increased secretion of thick mucus in the airway is what we're going to see here, okay? And it can cause either a fully obstructed or a partial obstructed airway. Sometimes they'll develop something called status asthmaticus, where they have back-to-back asthma attacks. That's a medical emergency. So coughing, tight chest, wheezing, rapid labor breathing, thick, sticky mucus, tachycardia, pulsus paradoxus, and hypoxia. They can develop respiratory alkalosis because they're breathing too fast. And if they're breathing too fast, what's coming out?
CO2.
Acid. Yep. Acid. So that's why they develop alkalosis. They could also develop acidosis if the air is trapped in the lungs. All right. But they'll likely develop severe respiratory distress no matter what. And that hypoventilation will lead to hypoxemia and respiratory acidosis. If it continues, they can end up in respiratory failure. And a sign of that is a decreasing level of responsiveness. So in acidosis, one of those signs are a decreasing level of responsiveness. Now think about that. Why? Okay. So it's acidosis, and I said it affects what? If you have acidosis,
central nervous system.
okay. So central nervous system, what arouses you?
The RAS.
The RAS. Okay, but if your central nervous system is depressed, your RAS will also be depressed. So your responsiveness or awareness is going to be depressed. Status asthmaticus, I just said it, okay? Persistent severe attack, and it can be fatal because of hypoxia and the acidosis. All right, emphysema, chronic bronchitis, and bronchiectasis. I would expect them to ask you probably at least emphysema and bronchiectasis. All right, so these are respiratory diseases. They cause irreversible and damage to the lungs. So when you have these chronic bronchitis, okay, eventually you're probably going to develop COPD. Causes debilitating lung conditions. It causes the development of cor pulmonale, which is right-sided heart failure. Right? Didn't we say that? Pulmonary disease will lead to right-sided heart failure, which is cor pulmonale. Look it up. What is it? Cor pulmonale. Somebody give me a definition. Who got it?
It says right-sided heart failure caused by chronic high blood pressure in the lungs, arteries, and hypertension resulting from lung disease like COPD.
Okay, you're going to see this again when you talk about heart failure.
Okay.
All right, so emphysema mostly caused by smoking. Here we have destruction of those alveolar walls. So they have no elasticity. Okay, you're going to see an impairment on expiration. Remember, I said at the end of expiration, that tissue is going to collapse and that air is going to be trapped. That is going to cause a barrel chest and hyperinflation. So you're going to have that hyper renaissance sound, a lot of air in that chest. Not much in the way of sputum. Okay. Chronic bronchitis, usually smoking and air pollution. My daughter has this every winter. She's probably going to end up with emphysema and COPD because guess what? She's still smoking those cigarettes. Okay? So increased mucus gland secretion, inflammation, infection, obstruction. They'll have a cough. They'll have a large amount of mucus or purulent mucus. They can have frequent infections. And it's common for them to develop right-sided heart failure. And then acute asthma. Remember, intrinsic means what?
Older adults.
Okay.
From the
Inside
Smoking.
inside your body.
Okay. And extrinsic is usually going to happen to.
Air of children coming from the air or mold, so forth.
Okay. Usually they have either secondhand smoke in the home. There's mold, pet dander, dust. So when we're teaching those parents about how to set up the home to protect their child from having asthma attacks, they got to eliminate all that. All right. And it's going to affect the small bronchial or the small bronchi. Here we have increased mucus, obstruction. Repeated attacks lead to damage. So when I say damage, remodeling of those airways is going to happen. Damage to the walls. They're going to have cough, shortness of breath, wheezing, and thick mucus. And again, status asthmaticus is a medical emergency. Emphysema, destruction of those alveolar walls. So the alveoli, they become large and permanently inflated. And it destroys the walls there, okay? Things that can contribute to it, the big one is going to be smoking. Okay, and this is just showing you a picture there of the emphysema, about how the capillaries are damaged, okay? The alveoli become overinflated. You lose the elastic fiber. The lungs can't recoil the way they're supposed to, and you have a decreased surface area for breathing. So it's going to affect their ability to breathe. They get air trapping. Look at how it collapses. You see how the damaged wall on the right side collapses and the air gets trapped. So their residual volume is going to be increased. And their lungs are going to be overinflated because of it. And it's going to damage them. They lose the surface area for the gas exchange. They lose the ability of those pulmonary capillaries, which again is going to affect gas exchange. They lose that elasticity. The lungs can't recoil. It affects the ability of the ventilation perfusion ratio. Remember, that's supposed to be equal. Fibrosis. Remember what happens with fibrosis. Now they're drinking through that paper straw, and that straw is collapsing and not letting them get that airflow they need. So they're going to have a problem with the expiration, air trapping, increased residual volume, overinflation of the lungs, fixation of the ribs, which leads to that barrel chest. The damage will eventually cause them to form large air spaces there. They can develop a pneumothorax if part of the area ruptures. Of course, increased carbon dioxide levels. What else will they develop? Anybody know? What do you think the body's going to do? For homeostasis here.
Gonna try to compensate somehow.
Okay. So it's going to do that by trying to produce red blood cells. Because the body knows that red blood cells can bring more oxygen to the body, right? What they'll end up is with mostly your COPDers, okay? But emphysema, I guess, could cause it too. They'll end up with excessive red blood cells, polycythemia, because the body's trying to produce more red blood cells in order to get more oxygen, but it just makes the blood thicker. They're still not going to get more oxygen because that's not what's broken. So look, pulmonary hypertension can develop here in right-sided heart failure. So that hypertension is in the lungs. If you've ever heard of pulmonary hypertension, that's where they're talking about in the lungs. And right-sided heart failure because it's pulmonary disease. So shortness of breath, first on exertion, eventually on at rest. Hyperventilation with a longer expiratory phase. Development of that barreled chest. And club fingers here. Chronic bronchitis, this is when we have obstruction, inflammation, repeated infections, chronic coughing, and it happens for 3 months or longer over a 2-year period. Again, the cigarettes are going to be the main cause of this. You could get it from living in an industrial area. I mean, if it wasn't really well controlled for some reason, or maybe if you work in an area where you have high exposure. Mucosa are going to be inflamed and swollen. You have hypertrophy and hyperplasia of the mucus glands. So that's going to cause fibrosis, thickening of that bronchial wall, low O2 sats, low oxygen in the body, severe dyspnea, so shortness of breath, fatigue. Again, it can eventually lead to pulmonary hypertension and cor pulmonale. So productive cough constantly, tachypnea, shortness of breath. Remember that mucus is going to be increased, so it's going to be thick and purulent, especially in the morning time. And then from that, we develop hypoxia, cyanosis. So remember, hypoxia is in the tissue, oxygen in the tissue. Hypercapnia, too much carbon dioxide. There's your polycythemia. Okay. Weight loss, signs of cor pulmonale. And then damage to the lungs as it progresses. And then bronchiectasis, I would know this, but what do they usually ask about this? Is about that it causes a thick mucus that's really funky. So I think it'll probably be on the next page. All right. Usually this is a secondary condition, and it causes abnormal dilation of the medium-sized bronchi. It comes from recurrent inflammation and infection. It causes obstruction of the airway, weakening of the muscle, elastic fibers, or both. And it can be caused by an infection like strep, staph, pneumo. What's the difference? Strep is a chain, staph is a cluster. Okay, cocci is balls. So it's a chain of balls, a cluster of balls, or balls that are infected by that pneumonia, balls that are infected by that H influenza. So cocci is little balls. Causes a chronic cough, a large amount of sputum, rales, rhonchi in the lungs. This is what they're going to ask you about for the bronchiectasis usually. So large amounts of sputum, and it's foul smelling. Rales and rhonchi, hemoptysis. You coughed it up, I got to mop it up. Weight loss, anemia, fatigue. All right, restrictive lung disorders. This is a group of orders that cause the lung expansion to be impaired, and it also affects your total lung capacity. So here we have abnormality of the chest wall, which limits or impairs the lung expansion. So those of you that heard me do the speech about kyphosis when we were doing muscular issues, kyphosis can affect this. That's that hunchback, okay? And it affects the ability of the chest wall to expand. Scoliosis, poliomyelitis, again, that's going to affect the skeletal muscles. ALS, which is amyotrophic lateral sclerosis. So that's going to affect the muscles of the respiratory system. ALS. And botulism and muscular dystrophy. Botulism usually you get from like buying those cans at ShopRite that are 10 cents because they're dented. And there's little holes in the can that allow bacteria to enter and make the food deadly. It also can come from like unpasteurized milk. And then muscular dystrophy, you're going to see this in Duchenne's muscular dystrophy. That's the one we talk about the most. That's the one that falls on the X link. So boys usually get it because they only have one X. Mom usually gives it to them. And it's autosomal recessive. All right. So you also have a group of diseases that are idiopathic, like pulmonary fibrosis. Remember, fibrosis makes the tissue unusable. So again, it's like drinking out of a straw that's going to collapse. Or occupational diseases. So exposure to some sort of chemicals or something that got into your lungs. Okay, idiopathic means the idiots don't know how you got it. Pneumoconiosis. This is a chronic restrictive disease, and this is from exposure to irritating particles. It causes inflammation, gradual destruction of the connective tissue, and it causes the functional area of the lung to be lost. It's a slow onset. They'll develop shortness of breath first, or dyspnea. So you might see this in people that work in the coal mines, people that were exposed to asbestos, or farmers. Okay, all of them exposed to some sort of agent. Like, remember with the farmers, I said in the dust, the hay, funguses, asbestos from the buildings. And this was before a lot of people were exposed before they decided, hey, don't do that. Coal miners, okay, they had all that coal dust in their lungs. All right, some vascular disorders, pulmonary edema and pulmonary embolus. So with edema, we have fluid in the alveoli or the interstitial area. This can be caused by a few different conditions, but it reduces the amount of oxygen that's going into the blood, and it interferes with the ability of the lungs to expand. All right, so this is going to increase the permeability of those capillaries, right? So that causes inflammation. The protein levels are going to be low. So remember that albumin does what? What's albumin do? Albumin is one of those big proteins in your body. What's it do?
It keeps the fluid inside the blood vessels.
It keeps the fluid in the vessel. Okay, so it helps maintain your osmotic pressure. Here, the osmotic pressure is decreased. So if you don't have enough albumin, it can cause fluid to go into your lungs where it doesn't belong. Okay, and cause one of these restrictive lung diseases. Pulmonary hypertension will develop because of that. All right, remember, pulmonary hypertension can lead to what? How's it going to affect the heart?
Right-sided heart failure?
Right-side heart failure.
Yeah, it can lead to heart failure. Okay. All right. So myopulmonary edema signs are going to be cough, orthopnea, rales. Okay, increased congestion. Usually we see pulmonary edema though with left-sided heart failure. Okay. Remember I said that, right? Pulmonary disease, right-sided heart failure. Pulmonary edema is usually a symptom of left-sided heart failure or some other issue, but usually left-sided heart failure. All right, they'll have a cough. They'll have orthopnea. What does that mean?
Where they have a difficulty breathing, they have to sit up when they're sleeping, or we have to keep them like in 30-degree.
Okay, good. You have to put them at some sort of angle when they're sleeping. They can't lie flat. Okay, rales, that's going to be those serous secretions. And then if the congestion gets worse, You'll see the hemoptysis. I coughed it up. You got to mop it up. The sputum looks frothy. Okay. So frothy means like, did you ever see somebody pour a beer? If they pour it on the top of the beer before it settles, what's it look like? It's foamy looking, right? So frothy is like bubbly looking, like foamy looking. Hypoxemia increases. Hypoxemia is going to be in the
blood.
Okay. And then a pulmonary embolus. This is where you have a clot or a mass that obstructs the pulmonary artery. Okay. It can be silent. It can come from the legs. It's going to cause chest pain. It's going to cause shortness of breath. The larger it is, the more it's going to affect. So if it's larger, it's going to cause severe chest pain, increased in the rate of breathing, so tachypnea, and then shortness of breath, eventually hemoptysis, fever, hypoxia. So your client will be restless. They might develop pallor, meaning they lose the color to their skin, and tachycardia with the increased start rate. All right. If it's massive, then it can cause severe crushing chest pain, a low blood pressure, a rapid weak pulse, and they can lose consciousness. All right, expansion disorders. These are atelectasis, pleural effusion, pneumothorax, flail chest. That's usually coming from multiple rib fracture, infant respiratory distress, and acute respiratory failure. All right, so atelectasis is where the lung is not inflating, and it causes a decrease in the gas exchange and a problem with the oxygenation in the tissues, so hypoxia. The alveoli become airless, so they collapse, and that interferes with blood flow through the lung. The ventilation and the perfusion are altered, and it affects the ability of the oxygen to diffuse. So gas exchange is going to be impaired here. All right. Things that can cause this. Some sort of obstruction, all right, of the airway. A tumor putting pressure on part of the lung. Increased surface tension in the alveoli, which prevents the expansion. Fibrotic tissue. It can restrict the expansion. So remember that fibrosis in the lungs we talked about. And then after surgery, sometimes lungs can collapse. So what will it look like? If it's small, sometimes we don't even know they have it until we do some sort of a test. Large areas will cause shortness of breath, increased heart and respiratory rates, and chest pain. And then the pleural effusion is when we have too much fluid in the pleural cavity. We have an increased pressure there. It's usually caused by either some sort of effusion. So we have this exudative effusion in response to some sort of inflammation in the body. And those effusions can be watery, or it can be from too much hydrostatic pressure, not enough osmotic pressure. So maybe the person's an alcoholic, their osmotic pressure is low. Signs and symptoms: shortness of breath, chest pain, increased respiratory and heart rates. Again, if there's fluid in there, we're going to have a dullness because it's going to consolidate. And with a pneumothorax, especially a tension pneumothorax, it can cause the trachea to deviate and the blood pressure to plummet. So what does that mean? The trachea can shift to the right or the left, depending on what part of the body is being affected here. So the pneumothorax, that's a medical emergency. I'm sorry, the tension pneumothorax is a medical emergency. With a regular pneumothorax, okay, they're going to have air in the cavity. It could be closed where air is entering from some internal airway and there's no opening in the chest wall. It could be simple or spontaneous pneumothorax. So the tear is on the surface of the lung. Or it could be associated with some sort of respiratory condition. Rupture of one of those emphysema blebs. Remember that we talked about. Or erosion of a tumor. from tuberculosis or cavitation of that tuberculosis. So 3 different types. Okay, you have a closed pneumothorax. This can happen spontaneously. The open one is usually caused by like a stab wound. Somebody gets stabbed in the chest, and that causes that open pneumothorax. And then the tension one can be from either a puncture, so it could be from the stab, or from a tear on the lung surface. All 3 of them cause atelectasis. Okay. And the shift you'll usually see with either the tension pneumothorax. Sometimes you might see a problem with the open one, but usually the tension. Now, the difference, tension pneumothorax is the worst, and that usually causes that tracheal deviation. Okay, shock. The open one is going to lead to things like a sucking noise, because why? You have a puncture in the wound, so it's going to cause this sucking sound, and the blood pressure is going to drop. And then with the closed pneumothorax, usually we just can't hear the breath sounds, and they might have hypoxemia. So that's the 3 differences that you're going to see there. Open pneumothorax, here we have air entering the pleural cavity. Sucking wound, usually like a stab wound. Tension pneumothorax is the most serious. Here we have the opening through the chest wall and the parietal pleura, either from some sort of tear or some sort of damage there. Air gets into that pleural cavity, okay, on inspiration, but the hole closes on expiration. Usually with one of these, we'll cover it, okay? Just like if your chest tube came out, okay? If you had a chest tube to inflate the lungs and that chest tube came out, we're going to cover that area to try to control the pressure. Because remember, your air has to come in through your lungs. In order for that to happen, what has to happen with the pressure in the lung for the air to come in?
I think it has to be low.
Yeah, pressure has to be low, okay, for that air to come in. If there's too much pressure in there, it's not going to come in. So like when the chest tube comes out, we can help fix that a little bit. What we'll do is we'll put either an occlusive dressing, or we'll put like a dressing with 3 sides taped down, so it allows some of the air to escape. If the air is trapped, that's going to increase the pressure in there and cause that atelectasis. All right, so with any sort of pneumothorax, regardless, it can lead to atelectasis, shortness of breath, cough, chest pain, unequal chest expansion, hypotension. Flail chest, again, is fracture of the ribs. Okay, so your ribs kind of move like an organ. And if one's broken, usually it can still happen. Usually if you have multiple broken ribs, then it affects that movement of the ribs, and that prevents expansion of the lungs. Okay, so during inspiration, the flail or the broken section moves inward instead of outward. That prevents expansion of the lungs. It can compress the adjacent lung tissue. The unstable failed section will push outward and increase the pressure in the lungs. It can cause paradoxical movement of the ribs, which alters the airflow during expiration, and hypoxia. Infant respiratory distress. This is usually related to premature birth. So they don't have enough surfactant in the alveoli, all right, or it's poorly developed and they're not able to inflate, and it causes atelectasis, decreased pulmonary blood flow, severe hypoxia, poor lung perfusion, lack of surfactant. And the thing is, you could say, well, we'll just give them oxygen. Okay, they need surfactant, first of all. And we got to be careful with giving them oxygen because it can cause other problems. Because remember, they have very delicate vessels in the body. All right. So with these kids, they're going to have poor lung perfusion, lack of surfactant, infant respiratory distress, usually caused by prematurity. All right. Increased alveoli capillary permeability, meaning it's allowing things to leak through like fluid and protein that shouldn't be. So they'll have respiratory distress, frothy sputum, expiratory grunt. You can really hear that grunt in them too. Their blood pressure is going to drop because remember, it affects the circulation. Cyanosis, hypoxemia, decreased responsiveness. Of course, they're going to have a decreased responsiveness because if they're not breathing right, rapid and shallow, what are they retaining?
CO2.
And that's going to affect their
NS.
central nervous system. All right. Adult respiratory distress is from injury to the alveolar wall. So what kind of things do we see that with? An injury to that alveolar wall. What would cause that? One for sure. Emphysema, yep. Causes the release of chemical mediators. That causes an increase in the permeability. So again, we have increased fluid and protein going into areas it shouldn't be in. Damage to the surfactant producing cells. So our surfactant levels aren't going to be appropriate. Necrosis and fibrosis. We already know necrosis breaks down and allows things to penetrate that shouldn't. And fibrosis is going to give us that feeling to try to drink through that broken straw. And a lot of times we'll see this in people that have multiple organ dysfunction. So it starts with septicemia, and that septicemia progresses to sepsis, septic shock, and MODS, or multiple organ dysfunction. Signs and symptoms: shortness of breath, restlessness, rapid shallow respirations, increased heart rate, and then they can develop both respiratory and metabolic acidosis, which is going to cause what? Acidosis causes what?
CNS depression.
Okay, so it can come from things like emphysema, any chronic or acute disorder, acute respiratory disorder, neuromuscular diseases. So they're talking about like Lou Gehrig's disease or Guillain-Barré syndrome, because that can ascend right up your legs and eventually affect your chest muscles and your respiratory muscles. All right, let's see what you learned. I'm going to try to record mobility for you. It's only 14 slides. You guys should be able to get that. Like, you know, I see that I don't have it recorded on there. So I'll try to record that in the morning, but it's only 14 slides. Okay, so when the diaphragm and the external muscles relax, external intercostal muscles relax, what happens?
We breathe out.
Think about it. When they relax, do they get bigger or smaller?
Smaller.
Smaller. We're not seeing the questions.
Oh,
Bigger.
my bad. Let me go back. Let me pull it up. Can you see it now?
Yes.
Okay.
Yes.
Okay, so when the diaphragm and the external costal muscles relax, the lungs are going to get smaller, right? The air is going to be forced out of the alveoli and out of the lungs, okay? So that means the pressure in the lungs is going to what?
Decrease.
Increase.
Um,
Whenever the air is leaving the lungs and going out into the atmosphere, remember air pressure moves from what?
high to low.
It's
High to low. So wherever the pressure is coming from, it has to be higher than wherever it's going to. Okay? Vital capacity is what?
C.
A.
The amount of air that can be moved in and out. Okay.
See why C is wrong? The amount of air that can be held in excess of normal quiet inspiration.
Okay.
The central chemoreceptors in the medulla respond quickly to slight elevations in what?
A.
Right. Elevations in the carbon dioxide levels, because those carbon dioxide levels represent what?
I'm sorry, can you repeat that second part?
Slight elevations in PaCO2, because CO2 represents what in the body?
Carbon dioxide.
Which is a
Acid.
acid. Okay. So let's just go back for a second. Well, I can leave it here and discuss it. Okay. Oxygen levels have to decrease significantly for your body to respond. Okay. That's only going to happen mostly in your COPDers because of their sensitivity to the carbon dioxide. Okay. And decreased hydrogen ions is meaning that your acid levels are going down. The chemoreceptors are going to respond to the increase, not to the decrease. Okay. Peripheral chemoreceptors located in the carotid bodies at the bifurcation of the common carotid arteries and in the aortic body in the aortic arch are sensitive to what?
Decrease oxygen levels.
oxygen levels.
Good. Okay, so now you know that the chemoreceptors, okay, let's go back. The central chemoreceptors are responsive to the carbon dioxide levels. The peripheral chemoreceptors are responsive to the decreased oxygen levels. Boyle's law means what?
See?
Which one?
A.
The high pressure to. Oh wait, hold on.
So as the chest cavity or the thoracic cavity decreases or gets smaller, what happens to the pressure?
Increases.
Pressure
increases.
increases.
Okay. The second one says as the size of the thoracic cavity decreases, the pressure inside decreases. Is that true?
No.
No.
No. Each gas in a mixture moves or diffuses according to its own partial pressure gradient and independent of other gases. That is what?
False.
Dalton's law. Remember? That is Dalton's law. A is Boyle's law. C is Dalton's law. I'm sorry? I'm sorry, what did you say? Don't be taking pictures of my questions. All right, I want you to understand the concept. Memorizing the question is not going to help you, okay? Because I had somebody tell me a couple of weeks ago that nothing that I was teaching was on that test.
That's weird.
Yes, it's weird because everything I'm teaching is on that test, okay? But it's not going to be black and white the way I'm giving it to you. If you understand the concept and you read the question and understand the question and thoroughly read your answer choices, You should be able to get to the answer. Okay? Too much carbon dioxide in the blood. So when we have too much carbon dioxide, we have too much what?
Acid.
Acid. And too much acid causes what?
CNS.
Acidosis.
Okay, so just look at the answer choices. Okay, 3 of them say what?
Alkalosis.
Okay, the one that doesn't,
that's a good
one
one.
of these things is not like the other. One of these things is different, you know. Look for things that are different. It doesn't mean it's the answer. Okay, but look at the other answer choices again. Alkalosis and anxiety. Alkalosis is caused by what?
Too little acid in the blood.
Not enough carbon dioxide. So right away you can eliminate anything that says alkalosis. And alkalosis doesn't cause CNS depression. What does it cause?
Irritant.
Right. Irritation to that central nervous system. How do the kidneys compensate effectively for respiratory acidosis?
Get rid of the hydrogen ion.
Right.
Yes.
Eliminate.
Okay, so if we eliminate bicarb, what are we going to become?
Bicarb is the base, so it's gonna be more acidotic. So.
Right. So we don't want that because that's going to kill us, right?
Yes.
How about if we reabsorb more hydrogen ions? What's going to happen?
More hydrogen, you're gonna get more acid.
Okay. Now, the kidneys, do they increase the respiratory rate?
No. No.
That's done by what?
Oh,
The pons, the
Or the
medulla,
medulla.
and the lungs are eventually affected, right? But if the kidneys make more bicarb, then the body will become what?
like in equilibrium.
Less acidic.
Mhm.
It's also going to try to have you blow off some of that acid, right? By changing your breathing. But when we've blown off as much as we can and the lungs can no longer compensate, then the kidneys are going to do another move. Carbon dioxide attached to an amino group on the hemoglobin molecule is called what?
B.
Carbamino.
Carbamino hemoglobin. Okay, if oxygen is attached, then it's called what?
Oxyhemoglobin.
Oxyhemoglobin. And bicarb is what?
Base.
It's a base. Okay, the kidneys really control the bicarb in the body. Okay. Chest wall rigidity is lost, resulting in paradoxical or opposite movement during inspiration and expiration. A sequence of pressure changes follows, affecting ventilation and oxygen levels.
B.
Okay. Flail chest. The closed pneumothorax, remember, that's a pneumothorax that can be caused by some sort of tear or something like that, but there's no opening in the chest wall. ARDS is acute respiratory distress syndrome, and TB is tuberculosis. Okay, remember, tuberculosis comes from microfast acid bacillus. It causes those granulomas, those tubercules in the lungs. Acute respiratory distress can be caused by a lot of things. Respiratory failure is indicated when what? So remember, what should your carbon dioxide level be?
35 to 45, 40. 35 to please.
What do you think your O2 sat should be?
90 to 100.
And here your pH is increasing and it's greater than 7.45. So that would make it what?
Acid.
If it's over 7.45? Oh, wait a
It's
minute. It's
alkalytic.
less than
It's less than.
7.45, right? Less
It's
than. That's the
it's
less
less
than
than
sign, right? I always get these mixed up. That's the
less
less
than
than sign in front of the 7.45, right?
Yes.
No.
It's
No, that's
greater.
greater. Greater than 7.45.
Okay.
Uh-huh. So that's acid, right?
Mm-hmm.
No, the higher you go, the more alkalytic.
Okay, so above 7.45 would be alkalosis. Below 7.3 would be what?
Acidic.
Acidosis.
Acidic. Okay, so here we have an O2 that's less than 50. That's not very good because I think that the O2 should probably be between 80 and 100.
Mhm.
Okay, the PCO2 is greater than 50, so that means we have some sort of acidosis going on, right? Because remember, when the pH goes down, here our pH is going down. How's our CO2 going? Up. Remember, respiratory is opposite, metabolic is equal. Remember that, Rome?
Mm-hmm.
What does that mean? Respiratory is opposite, metabolic is equal. So here, respiratory is going up, but our pH is going down. Our CO2 is going up and our pH is going down. That means we're becoming acidotic and our O2 sats are dropping. Okay. On the top, we have our pH is going above 7.45. So we're going to be a little alkalotic here. Notice that the pH is going up. What's happening with the PaCO2? It's not normal, but it's greater than 25. Right? Your PaCO2 is going to fall below 35 when you're alkalotic because it's going down, your pH is going up. But your O2 sats are still at 80. They're less than 80. We don't know what. Okay? So if you had to pick between the two of these, which one do you think indicates respiratory failure?
B.
B.
Okay, so everything we just talked about pretty much there, right? Acute renal failure, you won't have to read, by the way. You're not going to get problems that hard. I gave you that because I just want to see where your brain is. But mostly they're going to expect you to be able to identify whether it's acidosis or alkalosis and what symptoms will we see in the body. Okay, what causes acidosis versus alkalosis? All right, acute respiratory failure can result from what?
Flu? Influenza?
Influenza for acute respiratory failure?
Okay. That's
Maybe.
trauma.
So I think this might be a select all that apply.
Yeah. It's two of them.
Yeah.
It doesn't say.
Let's see what it says.
Mm-hmm.
Okay, I wouldn't expect influenza to cause this unless they had some other problem. But first, they would have to develop pneumonia. So it's a stretch.
Mm.
But if they had emphysema, they're definitely at risk. If they have some sort of flail chest or tension pneumothorax, they are at risk. And ALS, myasthenia gravis, they are at risk.
Mm-hmm.
Okay, myasthenia gravis, you don't have enough acetylcholine, your muscles are weak, they're not going to work right. Signs of acute respiratory failure. What's it going to look like?
Big, shallow, often liver respiration.
So if we have shallow respirations, what else are we going to have in the body? Too much what?
Acidosis.
Increased of
Okay. And if we
CO2.
have acidosis, how's it going to affect us?
Headache, lethargy, got it.
How's it
It's
going to
gonna
affect the
suppress the
body?
CNS.
Thank you. And the CNS depression is going to lead to what? Tachycardia, headache, confusion. Okay? Got it?
Got it.
What's the difference between an infant and adult respiratory distress syndrome? This is a select all that apply.
A.
B,
I think it's E.
C.
A,
No,
B,
no.
A, B,
A, B, C, D.
C, and D.
Because if you pick E, then you're saying that C and D are
It's
not
on
true.
2. Right. So A, B, C, D.
A defect in the exocrine gland causes abnormally thick secretions such as tenacious mucus. The primary effects are seen in the lungs and the pancreas, where the sticky mucus obstructs the passages. Other tissues are affected less frequently.
D,
It's the
fibrosis.
fibrosis.
Okay, bronchiolitis is the same as,
RSV.
and it's spread by
Droplet.
droplets, and it's usually kids between the ages of
2
2
and
to
3.
12
Right.
months. 2 to 12
Mhm.
months, I think it is.
Mhm.
They probably won't ask you an age group. I just want you to have an idea and see what you retained. Asthma, 2 types. What are they?
Intrinsic and extrinsic.
Okay, extrinsic is caused by
Air or mold,
Pollen,
pet dander, dust.
Allergy.
Blah, blah, blah.
okay, intrinsic. We usually see in
And the
Adults.
kids.
adults.
okay, and it's usually triggered by smoking or a bronchial infection or something like that. Cystic fibrosis, that's
A whole
this,
bunch of
right?
Genetic.
Sticky, yeah.
And
Yeah.
emphysema caused by,
Smoking.
and it does what? What's it do to the alveoli?
Make it fibrous.
Collapse.
It destroys it, okay? It
It's
destroys
drowsy.
it. Remember, it's going to overinflate, and then it's going to cause those air spaces. So it destroys the alveolar wall. That's what you'll probably see. Which is not a manifestation of cystic fibrosis.
B.
C.
C,
Exceeding normal
C as in
milestone.
cat.
C.
C, they do not exceed the normal growth milestones, okay? They will have a meconium ileus at birth. What does that mean?
That's
fat,
the first
sugar,
poop, right?
They don't have that first poop, okay? That green poop, that green sticky poop that usually comes out, does not usually come out with them. Fatty stools, they'll have it. Salty skin, they'll have it. Failure to gain weight, I'm sorry, is
Okay.
going to cause that lack of normal growth because kids have a high metabolism. They need those calories. They need that nutrition.
Oh, B and C. Okay.
No, B is wrong. I don't know why that's checked. Okay.
So it says which is not a manifestation. So I thought with the cystic fibrosis being so they have
They
all
do
of
have
that.
the meconium ileus at birth.
Okay.
Okay, let me just look it up, make sure I got it right. So they do have the
It says
meconium
that.
ileus because the meconium ileus is the lack of the production. Okay, so that's wrong. That shouldn't be highlighted there.
Okay. Repeat that again. What is-
They do have a meconium ileus at birth usually, The meconian illus means that they don't produce the stool because it's blocked.
It's at the
That's what it
top of
means.
page 297.
That's what
Just
it
so you know,
means.
in our book.
That the ileus means that they don't produce the poop, okay? It blocks it. All right. In this cancer, the cells are smaller and round. It spreads rapidly and has a high mortality rate. Smoking is associated with it. Small cell lung cancer. Good. Characteristics of aspirate determine the specific effect on the respiratory function. For example, vomitus may contain solid objects as well as highly acidic gastric secretions, lipids, or alcohol. The common result is what?
Obstruction.
Result D, obstruction.
Okay, when do we see D? What do we see D with? Remodeling of the airway. What did I say?
With asthma patients?
Asthma, your intrinsic ones. I mean, your extrinsic ones mostly, because they have multiple asthma attacks, right? Your people with intrinsic only have it like when they get an adult and once in a while, but extrinsic, they have multiple asthma attacks usually. So that's what causes a remodeling of that airway, is it's happening over and over and over again. It's damaging it. Destruction of the alveoli comes with what? What disease?
Emphysema?
Emphysema?
Okay. May accompany bronchiogenic carcinoma when the tumor secretes hormones or a hormone-like substance. Well, think about it. Mesothelioma is what?
Cancer.
That's usually from exposure to asbestos. Okay.
Asbestos.
A pneumothorax. Okay.
It's not
Thorax
the-
is the chest. Pneumo is what?
Collapse lung.
Air.
Air.
It's air. Pneumo is air. So you have air in the lungs where it doesn't belong. Okay. We talked about the pneumothorax. You can have a pneumothorax that is closed, one that's open, or one that is a tension pneumothorax. So this is not associated with this, right? Remember what I said? Use what you know to get to what you don't know. Pleural fusion is what?
Fluid buildup.
In that
Something in the
pleural
pleural space.
cavity.
Pleural space,
Where's the
yeah.
pleural cavity? Where is it? What's the pleural help do?
Help with the movement of the lungs.
Right. So where
Where
is
the
it?
surfactant
It's a
is.
sac around the lung, right? So which one causes the production of these hormones?
The paraneoplastic syndrome.
Paraneoplastic syndrome. Good. Use what you know to get to what you don't know. If you don't answer every question like this, you're doing yourself a disservice. Okay, I read the question first. I go from the bottom up. Systemic signs of lung cancer include, is fatigue a systemic sign?
Yes.
Then pick it. Hemoptysis, when the tumor erodes tissue, is that a systemic sign?
I don't know.
If you're not sure, leave it. What about anemia?
Yes.
Yes.
What about weight loss?
Yes.
Yes.
Okay, so which one do you think is not true?
See,
What's hemoptysis?
you spit it, you cough it up, we mop it up.
Blood.
Right, the tissue erodes. That's more of a local effect, right?
Yes.
Systemic signs, weight loss, anemia, and fatigue. Paraneoplastic syndrome. That's from that hormone secretion. What other signs will you see? Productive cough, shortness of breath, wheezing. These are all local things. That's it. All right, let's go over mobility real quick. All right. I got all day. What do you guys got? It's 14 slides. It's 14 slides. Let's see what we got. All right. You want to know these different meanings. Okay. Hemiplegia, that is paralysis on one side of the body. Okay. So like the left side. Paraplegia means paralysis of the lower half. You can't use from the waist down. Quadriplegia is going to affect all four. And diplegia would mean like both sides of your face or both hands. Okay? It's symmetrical paralysis in any part of the body. All right, so what happens when we don't use the muscles? We lose the strength, the endurance, and the mass. How many of you have ever been in the hospital just for a couple of days and you get up to leave and you're like, damn, I was only in here for a couple of days. What happened? All right, even if you're on bed rest because you had COVID or something like that. All right, so the muscles will start to atrophy. With prolonged bed rest, you can lose half of the muscle strength. So look it up in your book because they like to ask about that. How long would it take you to lose that muscle strength? Somebody look it up in the book for me. It's in there. And let us know what it says, okay? And then correct positioning, okay? Your person has to be correctly positioned or it can mess you up. So here you go. Here's your answer. After 3 to 5 weeks of immobility because of bed rest, almost half of your muscular strength is lost. Okay, so we have to have correct positioning of the immobilized joints because otherwise it can cause in a stretching or shortening or abnormal fixation. Even like putting a blanket on your older people's ankles, a heavy blanket can cause a contracture or a problem, okay, because it puts excessive pressure on the foot. And remember, as you get older, your skeletal muscles get weaker. You don't use them as much. Also, your flexor muscles, they're usually stronger than your opposing extensor muscles. Okay, so the extensor muscles will atrophy more than the flexor muscles. And that can cause an inactive joint to take an abnormal position if we don't maintain the positioning.
Miss Susan, can you pull the slide up?
Oh, I'm sorry. Got it?
It's not that much better, but okay.
No, it's not. It's
So I can make it larger, but I was using my notes. You need it larger?
Okay, I see the notes at the bottom. I didn't see it.
How's that? Better?
Yeah, it's better.
I just went into my notes because I want to make sure I gave you the right thing for the loss of strength. So 3 to 5 weeks, okay? Prolonged bed rest of 3 to 5 weeks can cause you to lose half of the muscle strength. And then the bone mass, okay? So this is why people develop osteoporosis because they don't do weight-bearing exercises or they're on bed rest for a long period of time. Now it reduces the osteoblastic. Osteoblastic is what?
The building.
New bones.
New bones. We're building new bones. So the body's not building new bone here, but it's still reabsorbing and removing the bone. And that causes the bone to break down and causes it to demineralize. Okay? So they develop osteoporosis. Tendons and ligaments, we have to move those. If we don't, they'll start to shorten. Okay? And that can result in contractures or limited function. So you see some of the people in the nursing home that have the contractures, right? If you try to straighten out their fingers or their hands, you can't, right? They're going to have that tendon or that ligament operated on for that to happen because it's permanently shortened. Here's a patient here with muscular dystrophy and he has contractures of the ankles there. And it's permanently fixed that way. You can't, even if you try to push the foot up, you can't. All right. So skin will break down if the circulation is impaired. and the cells aren't able to regenerate. The blood supply is going to be reduced here wherever the skin is stretched over those bony areas. There's not enough fatty or muscular tissue there to cushion the weight of the body, and that makes the areas vulnerable, okay, to ischemia. All right, and so we can have damage there to anything that's a bony area, like the sacral area, the hips, the heels, the elbows. Okay, what other things are they going to talk to you about? So anything that promotes breakdown. So circulation, edema, loss of sensation, like in your diabetics. So that's why diabetics are supposed to look at the bottom of their feet in a mirror every day. Any sort of irritation or friction. So if they slide down on the sheets, or if you're rubbing against something, too much moisture or perspiration. So if you look at your Braden scale, this is all things that it talks about. Okay. If you don't wash your booty enough, inadequate personal hygiene, inadequate nutrition, or not drinking enough fluids, any trauma to the skin, all these are going to contribute. What else do you have to know? What kind of effects is it going to have on the heart? Okay. So if you're immobilized, you're in a horizontal position. So that means blood is coming back to the heart by gravity. What happens is if the skeletal muscles are weak, they're not working well, it'll tend to pull in the trunk, especially in the lungs. Okay, now we have an increased venous return, and that causes increased intracardial pressure in the heart. That can increase the heart rate and the stroke volume. It actually can put more workload on the heart. Lack of muscular activity impairs the venous return. That causes the pooling of the blood, especially in those dependent areas. They can develop edema. We'll have a decrease in cardiac output, and that can lead to orthostatic hypotension, dizziness, fainting, falling whenever they change positions. If the patient has any kind of issue like cancer, it can affect them as far as blood clotting and also dehydration. Okay, patient becomes mobile after long bed rest. It can take weeks for these cardiovascular changes to come back. So that reflex that controls your blood pressure, that controls part of this, it's going to take time for that to go back to work. All right, so want to make sure that they have adequate circulation. You want to make sure that they're sitting on the side of the bed, letting those legs dangle before they get up so they don't fall. Whenever the blood pools or sits somewhere, it causes an increase in capillary pressure and edema. This promotes the formation of clots, okay, especially in your legs. And that blood clotting can cause that blood clot to eventually break off and go to your lungs, where it becomes a pulmonary emboli. And that can happen if we massage the area, or sometimes if they get up and walk. So they might develop this thrombus in their leg, get up and walk to the bathroom, okay, with your assistance, and the blood clot breaks off and goes to the lung. So we have something here called Virchow's triad. Okay, Virchow's triad is when you have venous stasis, hypercoagulability, and blood vessel damage. And those three things put you at a higher risk for a blood clot. It's called Virchow's triad. Virchow. Okay. And those three things, being on bed rest. Okay. So that means the blood's not moving. That circulation isn't good. Hypercoagulability. Who would have that? People that have sickle cell. People that have COPD because of that polycythemia. People that have, that take estrogen. People that are smokers. And then blood vessel damage, who would have that? Okay. People that are diabetics, people that have high blood pressure, people that are drug users, people that have varicose veins. So depending on the problem, all right, what are we going to have to do for these people? Respiratory effects can happen. So when you're laying flat, you have a decrease in the metabolism. That means you need less oxygen. Okay, so this puts you at a higher risk. for certain things. All right. If you have an infection, then your metabolic rate might be higher because of the infection. But usually, the respirations are going to become slower and shallower because you're immobilized and you don't need as much oxygen. You don't need that metabolism is slowed down. Okay. So you don't need it as much. Deep breathing and coughing can become harder because of the weight of the body, and it puts pressure on the diaphragm, and that can restrict the chest expansion. They can develop secretions in the lungs from laying around. That puts them at risk for pneumonia or for a collapsed lung or the alveoli not inflating like it's supposed to. Other things that could affect it are sedatives or analgesics, again, because they depress what?
The respiratory rate.
CNS.
Central nervous system, which ultimately, yes, will affect the respiratory rate. All right, digestively, we'll see a decrease in the dietary intake. Appetite is reduced. They can develop a negative nitrogen balance because they don't have enough protein. And remember, one of those proteins we talk about is what?
Albumin.
Albumin, and that's supposed to help maintain your osmotic pressure. Okay. So the major problem with immobility in the GI tract is constipation. Because we have immobility there, we have this hard stool that maybe doesn't have enough fluid coming into the intestines as well. So we have inactivity of the muscle from the body position, from laying around. We have a reduced food, fiber, and fluid intake. And then also obesity. So if someone's obese and they have prolonged immobility, all right, their caloric intake will often exceed what their body needs because the hand can still go to the mouth. So while they're laying around, they're taking in all this food. Let's see if there's anything else on there that you need to know. That's probably everything, but also, when you're in bed, like trying to use a bedpan, that don't always work, okay? Or trying to take a poop next to somebody in the room next to you, right? You don't want them to hear your sounds. You don't want them to smell your poop. So that's going to play a role too. Stasis of urine can happen here also if they're immobilized. So that urine's going to hang around in the bladder or the kidneys. That can lead to infection. It can lead to kidney stones. They're more likely in people with hypercalcemia. So hypercalcemia is what?
High calcium.
High calcium, okay? So my mnemonic for that high calcium is moans, groans, and kidney stones because too much calcium in the body is hard to get rid of. And if you have a lot of calcium in the body, it's going to cause kidney stones, bone pain, and constipation. So that's why I say moans, groans, kidney stones, okay? Moans from the bone pain, groans from the constipation, and kidney stones. Also bladder infection, especially if they're using a catheter. Now, also, we'll see an increase in diuresis there, meaning they're urinating, and that can lead to dehydration. Okay, so they're urinating a little more than often, and they're not always taking as much fluid in. Okay, so they can develop a bladder infection called cystitis, and from the excessive diuresis, the dehydration. Now, the problem with that is if they become dehydrated, then we have a low flow of urine coming into the kidneys. Okay, so first we have a blood shift because we're on gravity. Now, if we have a blood shift and we're on gravity and we have too much fluid going back to the heart, that can cause the release of what? When we have too much fluid going back to the heart, what does it cause us to release?
AMP.
Remember AMP, atrial natriuretic peptide? Remember I said when we have too much fluid coming back to the heart, it's going to cause the release of that AMP. That AMP is a snitch bitch, right? So that's going to go down to the kidneys and tell the kidneys to stop producing what? renin.
ADH.
And if it stops producing renin, then we won't have vasoconstriction and we won't have the release of aldosterone. We also can limit the release of antidiuretic hormone here. Okay? So the combination of these three things is going to cause us to do what? Put out more urine. And that urine going out can cause us to become dehydrated. You got it? All right, neurologically, okay, some of the effects that we'll see is continuous pressure on the skin. That can cause damage because our mechanoreceptors, our pain receptors are going to be released. You can have spasms, okay, from, lack of movement there. Damage to the nerves, innervation of the nerves, all that can lead to spasms. And also psychological effects because you can't control what's going on. So then these people can end up depressed, anxious. And then for kids, okay, how does it affect kids? So normal growth is going to be delayed here. All right, if they're immobilized for any extended period of the time. In addition, the physical movement to stimulate their bone growth and their muscle development is lost. So they might need to catch up. Typically, with these kids, we'll see deformities involving the hips, the spine, the hands, the feet. And depending on how, it affects them overall, it can also cause, sensory issues for them. Okay, remember, kids, they need to be around their friends. They need to be doing the norms. So it's going to affect them in other ways as well. All right, and that's it for chapter 25.
Thank you.
All right, questions on anything before I go?
You putting this on YouTube, right?
Yep.
Thanks, Ms. Loesch.
All right.
Thanks,
Thank
Ms.
you.
Lewis.
Thank you.
Thank you.